Hello everyone. I hope you all are doing well. Before we begin, could you please give me thumbs up in chat box if my voice is clear, my screen is visible, and you people are comfortable with audio and video. Okay. And I strongly recommend that you keep a notebook and pen with you. Throughout today's session, I will highlight very important one-liners, exam tips, and follow-up points. And trust me, they are worth writing down for revision. Once revision is ready, you will get started. So let's begin. And one another request. If you're enjoying the session and finding it's useful, please send a thumbs up in the chat. It really motivates me and encourages me to give you people my very best throughout the class. And if you have any questions, queries, please type them in chat box. You can simply start your message with, this is your query, okay? So let's start now with the name of Almighty. So we are going to start with very important module, early pregnancy. And trust me, I don't know why I have actually opened this Pandora box. Nobody actually for MRCPI start preparation with early pregnancy, because unlike other exams which you have previously, many of you have given like FCPS, MS or MRCOG, early pregnancy is special in MRCPI. Why it is special? Because Ireland has its own recommendations in 90% of the actually early pregnancy scenarios. Okay. And because, a huge list of guidelines, and many are very recent on this module. So you can easily actually anticipate in your 100 single best answer exam, approximately 10 plus questions from this short modules. And trust me, they will not be simple as you are feeling that they will be. Okay. So get ready for a lot of twist, and no worries. I trust me, after completing this session with me, every important tip and trick will be on your fingertips. Okay. You can easily crack it if you are, staying with me throughout this session. Okay. So give me thumbs up if you are ready. Okay. Come with, with this mind that we are going to learn so many new things. Okay. And, learning new things gives us some kind of excitement as well. So let's start. Okay. So in early pregnancy, you will see a lot of guidelines, and these 8 are very important. Interim guideline, it's about terminations. Ectopic pregnancy guideline, first trimester miscarriages guideline, early pregnancy complications guideline. Early pregnancy complications guideline basically is updated version of interim guideline. Okay. Then nausea vomiting in pregnancy guideline, then molar, and then about fetal anatomy. Okay. So if you know these 8 important guidelines, you can easily solve 9 plus questions in your exam. Okay. Pardon me if I have written wrong and publishing here, like I know ectopic has not been released in 2025. It was updated in 2024. Okay. So what you can expect in your exam from this module, you will see miscarriages questions, and they will be minimum 2 and maximum they can be 4. Okay. Then you will see ectopic pregnancy questions. Yasmin, what are you saying, my dear? If you guideline share in this group, I've already shared actually. You missed it. And I have shared it for everyone. It's my public group. Okay. So I think you missed it, Yasmin. I will tell you. Let me know after the session. So where we were, miscarriage is very important. Trust me, when I was working on this PPT since 3 and 4 days, and you can say 2/3 of my time was, utilized on, compiling the miscarriages related questions, like how you will treat recurrent miscarriages, how you will, treat a lot of, management of miscarriages, subproducts, so many things. They love miscarriages, that batch, and you will observe it with me as well. So they can be minimum 2 and they can be maximum up to 4. Okay, then you will see 2 and minimum 1 or 2 questions from a topic, and trust me, they are very straightforward. If you have done the summary and recommendations, it's enough. Okay, definitely they will give you mandatory 1 SBA, and it can be up to 2 as well, but 1 is mandatory in your exam. It will definitely come from PUL algorithm. Okay, and 1 SBA mandatory from recurrent miscarriage. 1 SBA is mandatory from hyperemesis gravidarum, or you can say Ireland nausea, vomiting, and pregnancy guideline. Actually, it's an older guideline, but they still love it. Then 1 question, and very predictable, will be from molar. And then you will see 1 mandatory question on, termination. Like they love this. And it's easy, not bad. Okay. And then 1 question, occasionally, not always, I will not say mandatory, from early pregnancy ultrasound, Irish guideline. Okay, they will test you about the soft tissue markers, and they will ask you how you will, intervene next. Obviously, there is a lot of tissue markers. Okay, so friends, miscarriages and pregnancy of unknown location and termination, they can give you a surprise in exam, but ectopic questions, hyperemesis questions, molar questions, they will be very straightforward. Okay, so let's start. Initially in the guideline, I have compiled every important thing, but I'm not going to teach you again theory. I have made a movie as well, but we will watch this movie at the end of this session. Okay, we will watch this movie together, and you will appreciate this movie as well. And then there are a lot of cards about termination grounds, about when to do fetocides, and abortion laws. So many flashcards you will read today with me, and so many exceptions you will observe today. And then we will actually cover few entity questions. Then we will compare recent updates in recurrent miscarriages, and after this we will start doses, they love it, and then ectopic cards, and then few calculations, and few signs, few traps, and few VT questions. Okay, in early pregnancy, you have to solve VT questions as well if the patient is having, hyperemesis gravidarum or anything having established risk factors. Okay, so earlier I was thinking I should actually teach you the theory. Then I thought we have already covered theory a lot. So why to start again from theory? So we will focus on the recalls. Okay. And I have picked every question right from 2016 till 2026. The recent one, which was your March 2026 exam. Every question, topic-wise, from miscarriage topic, from molar, from you will say ectopic, and about terminations. Okay, no worries. So basically, what we will do in our course, let me to explain. We will do 2 things together. Okay, in our course, and this is our trial session open for everyone. We will do 2 things together. One important arm is on paper-wise recalls. We have already started 2016 question paper, and we have covered 16 as well, and we are doing 2017 now. Okay, and second arm will be on module-wise recalls. Okay, so you will cover 2016, 17, and till 2020-26. Every recall which has been, in MRCPI pool, and you will revise them with me in a modular fashion as well. Okay, why? Why I have added this? Because you will see a lot of courses are just, focusing on paper-wise recalls. That's it. Okay. But in my opinion, if you are doing only paper-wise, students, how you will revise your theory? Because in paper you will see one question from early pregnancy, second question from labor, third question from oncology, fourth from general gynecology. Every day you will do so many random things. Who will complete your theory revision? Who will? And trust me, no doubt, you will see a lot of repeat questions. Okay, you will see a lot of repeat questions as maximum up to 60% in your exam. They will be, based somewhere from 2016 till 2026. They will be picked. But trust me, they will not be exactly 100% same. If they are picking any question from 2016, they will pick only the theme, right? And they can add one additional catch point. And just by adding that additional buzz, your actually ideal key will change. So cramming the paper is not logical thing. However, if you are doing the papers with logic, with evidence-based references, and you are covering your modules side by side, again in exam-oriented way, only then you will have a vision. Okay, so how to actually modify the key as per the buzz. So we will do these two things together. They are actually salient part of our fast track. Okay, so as I told you, we have already started paper wise activity. Now we will start module wise recalls, and after every 2 days there will be module wise drill. So in 3 days, I will ensure that your module will be revised, and we will not revise module again by repeating theory things which you have already covered. Many of you have done theory, I know, with me, with my course, or with individually, or maybe you have not done theory at all. Okay, no worries. But if you have obviously you have short time now. So if you will do theory with me, and only you will actually drill the questions which already has been tested as recalls, so you will be highly exam focused. Okay, and I told you 60-70% they test each time their themes. Every time they will give you one question from a topic, one from entire termination guideline, one from molar. Every time this is mandatory. 3 to 4 questions from miscarriages and 1 to from recurrent or from fetal anatomy. So they are they are very sure they will test you from these 10 concepts. But you are not sure that what will be those 10 questions if you have not prepared your theory as per exam expectations. So what we will do, we will focus on those 10 important exam themes where your recalls are coming up again and again. And in future, if any new buzz if added, you can easily crack it because you are not cramming it. Okay, it can actually, but what is the actual recommendation, and you can easily pick the right. Okay, now after this, we will start doing the real thing, because actually this is your recall session. So should we start? Ready? She's asking, is it possible to ace this exam in 50 days? Why not? After MRCOG 2, you have done actually 80% things. You just have to do, Aisha, only differences is like you have covered VBAC, I know, and you have covered breach as well. Now you just have to add that in Irish guideline, they don't want breach as VBAC. That's it. So there will be some exceptions, and I have actually, I'm coaching MRCG part 2, so I particularly actually I'm very interested to explain the difference there and then. So no worries, if you are in this course, you will have very clear idea where Irish guidelines are different. Okay, and you just have to add only 20% new things, 80% you already know. And basically this is the perfect time if you just have prepared and even failed in MRCOG 2. But if you have prepared for MRCOG 2, you can easily pass MRCPI exam. In my last batch, there were 2 or 3 students. Unfortunately, due to some reasons, they can't make in MRCOG Part 2, but they have passed their MRCPI with very, good scores. And in my last batch, one student joined us very late, and her score was 86%. And many of you have observed her feedback as well. Her video testimonial, I used to upload on my page as well. So it's highly doable. Post FCPS, post MRCOG Part 2, post MCPS, even post IMM, you can easily start your preparation if your exam is 50 days away and you can pass it. Trust me. But you have to study very smart. Okay? And smart study means you have to do papers and you have to do theory side by side, but in exam oriented way. Okay? So I'm taking too much time, but you have so many queries and I can't skip it. Okay, Yasmin is asking how to read Irish guidelines. These are too lengthy. Actually, Yasmin, Irish guidelines are not very much lengthy. Trust me. After this session, you will love Irish guidelines because beauty of Irish guidelines is that they are very easy to read and only you have to read the recommendations, means first 2 or 3 pages. That's it. And if you are doing it, you can pass it. I'm not saying you will score 100%, but you will pass. Okay. So another query. So one question, if we do your topic-wise module question and answer, does that cover past papers as well? Why not? We are doing paper-wise as well, so that you cannot miss any single question. Okay, and we are doing module-wise as well. So actually, basically, you are revising. You are revising. The same questions you are doing paper-wise and the same questions you are doing module-wise. But why we are doing module-wise? So that you can revise your theory. Okay? And it will be less cramming. Okay. So I think I have replied a lot of queries. And if you allow me to complete today's session, trust me, maybe there will be no query after this session. Okay? Yes. See, here we are. Okay? These are the flashcards. Okay. So the my PPT will be available on my portal as well. So after completing or listening my lecture, you don't have to listen me again. You can read my PPT as well. And you don't have to read actually the Irish guidelines. You have to read only these three things from Molar Irish guideline. One will be this follow-up, right? For complete and partial mole, and one will be the scoring. That's it. As I told you, molar questions are very predictable for this exam. One question will either be from follow-up or from will be the scoring. That's it. No surprise in molar. No surprise in ectopic at all. Okay. So, and here actually these till 106 page, till 106 page, you can see, here we are. So see, when you will see my module while recall study material on your portal, you will not just start blindly to read the recalls. No. First, you will read miscarriage, actually these important tables, right? You can see, and there will be a video we will see together in the end. Then there will be flashcards, and a lot of flashcards. And each flashcard is actually equal to 10 pages of your Irish guideline. Okay. So for example, there is a recurrent miscarriages pregnancy guideline, and 2 and 3 pages, trust me, are only about this on maternal age. And with this only single flashcard, you can easily do it. If age is less than 35, you need 2 consecutive miscarriages, right? And if age is 35 or more, you need 3 consecutive miscarriages to start karyotyping test. That's it. Okay. So, and tables as well. Okay. And so let's start. Okay. So we will start from the recent paper questions. Okay. I will provide you flashcard and last minute revision notes on your portal, and they will be separate. No worries. I know it will be difficult for you, specifically in the last week, to open so many resources. That's why you have joined the course, so that I can make your life easy. Okay. Yes, here we are. Yes. So let's start. So recently, in March 2026, the first question was this: a 28-year-old woman, and can I give you a tip as well? Because this is, you can see this is a long scenario. Okay, when you see scenario is long, you can read the first line as well. What they are actually asking, they are asking the appropriate line of any A, B, C scenario. Okay, so with this, important thing that you have to manage this patient appropriately. And what does it mean by appropriate? What does it mean? It means that as per individual situations, management will be individualized. Okay? Maybe for this patient, appropriate management will be different, and for second patient who is having certain risk factors will be different. Okay? So, and versus that, always remember, initial step is not appropriate. This is just, part of the very first part of the appropriate management. Like, for example, we are dealing with choreo. So choreo, primary management, primary keys, or appropriate management is delivery. You have to deliver. That's it. But if the key is initial, so then it will be antibiotics. Got it? Are you clear? So if you notice anywhere that the scenario is long, like we are reading here, so always just see the last line, what they are asking. They are asking appropriate management. Okay, so let's start from question, and you will read 2 time question. 1 time for orientation and 2 second time for the buzzword, catch points. And there are 2 things. Buzz are catch points, and second is leading. What is the leading edge? Leading edge is this. They are asking appropriate management. And what are the buzzword? They like the fever, the pulse, respiratory rate, tenderness, this RPOCs, they are the buzz. Okay. So first read will be, only the raw read. But second read should be, you should be able to pick your catch points and your leading clue, what they're asking, appropriate or initial. Am I clear? Okay. So remember, so first we will read a 28-year-old patient, para 1 attends the emergency department 10 days after a medical termination of pregnancy performed in primary care setting. At 8 weeks, she reports increasingly heavy vaginal bleeding over the preceding 24 hours, soaking 2 pads per hour. Soaking 4 pads per hour is an emergency, red flag. However, she is not soaking 4 pads per hour. She is soaking 2 pads per hour. But anyway, she is passing clots together with an offensive discharge and constant pain. Examination showing she is have fever, her pulse is 118, BP is 96/58, respiratory rate is 28, abdomen is tender, okay, and it is markedly tender. And cervical os is open because you can admit 1 fingertip. And you have done TVS as well. And TVS is showing a vascular intrauterine tissue with a maximum AP diameter of 35 mm and no adnexal mass, means no ectopic. White cells 21, obviously she is having fever. CRP is also raised. Lactate, you can see 2.6. She is having actually sepsis. Okay. So what is the most appropriate management? So you don't have to read it the second time as well, because we know this is a case of septic miscarriage and patient is having RPOCs, and we are here to, pick the appropriate key. So I will suggest you don't look at the options. After actually reading the scenario, close your eyes and actually visualize what should be the ideal key. So how you will treat her ideally? Sepsis 6, you will initiate sepsis 6 protocol. And IBO's trigger because she is having more than 2 yellow, right? And more than 1 pink. Okay. And after this, what you will do? What she need? She need a primary key is suction evacuation or surgical miscarriage. Okay. And sportive keys, she need admission, sepsis protocol, broad spectrum antibiotics, HDU care. Right? Agree? So with this actually ideal key, now read the choices and see what is closer towards the ideal key. That's it. So option E, oral 𝗂𝗪𝗃𝗧 with review in early pregnancy assessment. No, oral she's having sepsis, so I will want IV. B, IV antibiotics alone with evacuation deferred until she has been in trial for 24 hours. It's not the case actually. We don't wait for in 24 hours particularly. We give antibiotics and at the same time after this, we can start evacuation. Resuscitation, yes, this looks sound because look at her BP, pulse and temperature. Okay, IV broad spectrum antibiotics, yes. And urgent surgical evacuation. Obviously, we don't want to wait for 24 hours. So pick C and write it here. And now keep reading. Yes, misoprostol, no, because medical management is not ideal, in sepsis. Expectant, never. So easy peasy. So I have actually given here ample time so that in the same way, in exam, you will work on every question. If question is big, lengthy, you will start from last line. Always you will read 2 times. Second, read particularly to pinpoint your catch points and leading edge of the question, what they want to ask, right? And then you will not jump on reading the options. You will imagine the right key because by this activity, you will face less biasness and there will be more brainstorming, okay? And then actually pick the key which is more closer to the ideal. And if there is no ideal key, then keep eliminating, like this is not B, this is not B. And you can't actually know the answer. Even then you can make a wise key if you are eliminating. Like that she is having, that much fever and her pulse is that much. Obviously, this is a common sense. It will not be oral antibiotic. So somewhere you will stuck into B and C and you don't know about the septic miscarriage or sepsis protocol. But even then, you have an idea that at this BP, at this pulse, at this respiration, tenderness, she needs something urgent. So you can eliminate even then C because you can't wait for 24 hours. So even then, if you face in exam any topic you have not actually revise it well, and this is a very new topic for you, you can make a sensible key by this elimination way. Okay. So clinical sense is very important. So now I will cover your questions. Actually, more rapid, in a more rapid way, because this one question will give you an idea how you will actually attempt every question in your real exam. So this is C. Okay. Now question number 2. 24-year-old patient, 𝗪𝗵𝗹𝗹, attends the early pregnancy assessment unit. 4 weeks ago, she underwent medical. Okay, this is a very interesting question. Okay. Right. 4 weeks ago, she underwent medical termination of pregnancy in primary care. At the time she passed, she was assessed as being 7 weeks gestation on the basis of a certain LMP and no ultrasound was performed. She took mifepristone followed by misoprostol as prescribed, but reports that she had bleed only lightly for 2 days and that her pregnancy symptoms have persisted and intensified. So what does it mean? I will revise you now the interim guideline about termination, and you will see that at this gestation, we can treat patient if she is low risk for ectopic pregnancy without ultrasound. Ultrasound is not needed when patient is low risk for ectopic for medical termination. Okay, but if respected, then definitely we will do ultrasound. My voice is not clear, Uzma. Let me know in chat box if other than Uzma, someone also facing the same issue. Then definitely she will. Okay, no clear. Uzma, your signals are not clear actually. I think. Okay. So 𝗪𝗵𝗹𝗶. Okay. So definitely it's a routine. We don't do ultrasound, and same they did. And after this, she has taken, 𝗪𝗏 treatment, and she can take this in a primary care, on OPD base as well. But it was not a successful treatment because she has not aborted. She, has developed only bleeding, and her symptoms are persistent. So it means she is still pregnant. Now she's at 11 weeks. Okay, she is well. TVS has been done, and here you will see that CRL is 64. And I will show you, we can go for MTOP or for social abortions only if CRL is 63 or less than 63. Okay, or 12 plus 0 weeks or 84 days. But if baby is alive, pregnancy is ongoing, whether you have given earlier abortion drugs or not, at this CRL, for sure, you can't give any other treatment. Okay? And here you have, this. So what will be appropriate management with this knowledge? Prescribe, repeat? No. Voice is not clear. Okay. Voice gone. Voice. Now, distortion. Now it's okay. Okay. So, administer misoprostol, no, because at CRL more than 63, no termination is allowed on patient will. We can terminate only if patient life is at risk or baby is having, lethal anomalies. Okay, but not in this case. So out. So we are going to eliminate one by one. So this is also out. Refer to hospital-based termination pregnancy service. So one thing is sure, we will refer her. And they will decide whether termination services will decide she need termination or not. So it can be a possible option. Reassure, never. Okay, because she has taken abortifacient drugs, we will refer her. Why we should reassure her? Up to 4% risk of lethal fetal anomalies because of these drugs. Advise that no further intervention is possible and refer for antenatal care. Why? Intervention can be, like, we will definitely do her anomaly scan and we will discuss her treatment options, obviously, but for sure we will not terminate. But yes, she need counseling. And she is on the termination protocol. So we will refer her towards the hospital which are dealing her termination pregnancy services. But it does not mean that they will terminate her. Do not assume it. They have not written it. In exam, people have faced a lot of confusion here. So that's why I'm explaining. Okay. So query was in C versus E. So this is not a routine antenatal case. No. This is a very special case. You need a lot of psychological session. Can need psychological sessions as well. Fetal concerns, maternal concerns. So what you think? What is your clinical insight? C is better or E is better? Okay. Okay, you want C? Okay, so in my opinion, ties in C and T, because it's not a routine antenatal case now, right? And we are not sure pregnancy is unaffected. She has taken drugs, pregnancy can have 4.2% effect and develop complications and anomalies. And because of this, maybe we have to terminate. So D is not ideal. Okay. Okay, so let's read this explanation. Crown rump length 64 mm corresponds to approximately 12 plus 6 weeks. The scan dates the pregnancy, knows the LMP, and 11 weeks. We know that actually 11 weeks by LMP can be wrong. So CRL is more accurate. Okay. And then they said this is an ongoing pregnancy after failed medical termination, which complicate roughly up to 3% of cases. She is now beyond 12 weeks, so we can't terminate her according to the Ireland Abortion Act, and she can manage neither in the community as a routine case. But right, and the hospital service must confirm dating, assess her against the remaining grounds, and counsel her regarding the teratological effects of misoprostol exposure. Because I told you, she has taken medical termination, and they are actually in FDA category drugs X, and it comes in D. Few comes in D, and few comes under E. So better to actually refer her in hospital, and they will discuss her everything and other options and we will discuss, maybe she will fulfill other classes as well. Okay, so do not force her to she should be managed as a normal routine antenatal patient, and we can't intervene. We have to intervene, but not in terms of that we will do actually termination, but in other ways like her counseling, other choices. Okay. I know how I am hopeful it will be clear. The patient cannot simply receive another community-based termination. CRL is more than 63, and she requires urgent referral to the hospital-based top services where eligibility under the act will be reassessed by the specialist. Okay. Yes, 12 plus 0 crossed, no more terminations. Actually, she will be referred towards the consultants who are expert in terminations, but they are not here to terminate her. They are not here to that they will terminate her. Okay. The specialty service name is termination center, where experts are sitting and they counsel which patient need termination or not. That is the trick. Now clear? Referring her to the experts who are expert in terminations means that they are the perfect persons who can better judge that she is a case of termination or not. It doesn't mean they will definitely 100% will terminate while she has crossed 63. Okay, read again. So now let me know what is better. Referral to hospital-based termination of pregnancy services. Reassure her that pregnancy is unaffected. Pregnancies can be affected up to 4%. So D is out. And what about E? Advise her that no further intervention is possible. Why? Maybe an anomaly scan. We will see a lethal anomaly, and on this ground we have to terminate her. She is not a routine antenatal care patient. So E is out. So on elimination ground, where you actually you stay, let me know. You are assuming that she is going for termination. No, people are experts here. Hospital referral to hospital-based termination services means they will assess her whether she need or comes under termination any clause. Maybe in future she can come. Give me thumbs up, otherwise I will stay there. Okay. And among all options, the option C is actually the wise option. Okay, now coming towards, now I will stop here because you need to revise termination laws. Okay, so let's revise. So girls and friends, there are a few sections in Ireland. Can you see my new PPT? No, okay. It's not going to change. Now you can see I'm hopeful. Okay, so cram them. Section 9, termination of pregnancy may be carried out in accordance with the where to medical practitioners having examined the pregnant woman and are of reasonable opinion formed in good faith that there is a risk to the life or of a serious harm to the health of a pregnant woman, the fetus has not reached viability, it is appropriate to carry out termination in order to avoid the risk of pregnancy risk. Okay, so this is section 9. Section 10, termination of pregnancy may be carried out in accordance with this section by medical practitioner where they have examined her and she is of the reasonable option in good faith that there is an immediate risk to her life. Okay, so they can, to save her life, they can terminate under section 10. Section 11, a termination of pregnancy may be carried out in accordance with this section where two medical practitioners having examined the pregnant woman are of reasonable opinion. Okay, 𝗪𝗵𝗹𝗪. Section 11 are of the reasonable opinion formed in good faith that there is a present condition affecting the fetus is likely to lead to the death. Okay, fetal anomaly. Immediate threat to life. Okay, and risk to life. And 12, termination of pregnancy may be carried out accordance to the Okay, this is social abortion. And they are very different actually. I am also teaching, MRCG 2 as well, and there were different abortion laws. There are different abortion laws and the gestational ages. That's why I have to read it again. Okay, but it should be, if your exam is in, coming weeks, so please, it should be on your fingertips. What is section 9? What is section 10? What is section 11? What is section 12? Okay, and remember, when there is a risk to the immediate threat to the life of a pregnant woman, then there is no need that we should wait for signature of two medical practitioners. Okay, this is important. And yes, okay, definitely I will. So everyone know this, the abortion laws as per Ireland, and with little effort you can easily cram it. But in exam, they will not ask you which is actually which section is dealing or law is dealing which condition. Usually they will ask questions from social terminations, and you will face two type of scenarios. Scenario number 1, termination started, procedure began, but not completed. Okay, just imagine the same scenario which we have just discussed. In that, termination started. Right, MTOP's medical termination started. She actually experienced only light bleeding, and on TVS and on scan, a perfect viable pregnancy, CRL, FCA positive. Okay, so here we will not actually continue the MTOP. We will not give her another dose of misoprostol. Okay, but the same patient after MTOP comes, like we start her termination at 63. And after, 3 days, she comes with pain, her OC is open, she is bleeding, POCs are inside, few she has expelled. So what we will say? That as 63 days has been passed, so we will not terminate you. No, because termination process has started. Procedure began, but it is incomplete. So we have to complete the procedure. Whatever is her CRL, whether it is, more than 63. This thing clear, friends? This thing clear? Because definitely you will see this question somewhere in your, exam or in your OSCE. And you will say, no, because, 63 or 12 weeks has passed or 84 days crossed. So we will not. No, you will, because you have to complete the procedure. But the second scenario, termination started, but process of termination not commenced at all. There is a perfect viable fetus inside the uterus, and CRL has crossed 63 length. So why? Now it is illegal to provide repeat course. Refer her to the specialist of terminations. They will discuss her that if she is, fulfilling the other sections of abortions. If she is fulfilling other sections of abortions, then only then they will allow, otherwise they will not. But they will treat her as high risk patient, not a routine antenatal care patient. Clear? Where is your emojis? Yes, Safia, right. But I'm waiting for the emojis. I deserve here. Okay, so I told you if mother life is in danger, and before 24 weeks or any time, if we have to save mother lives, we have to terminate. But feticide is not recommended in every talk. It is only recommended if baby gestational age is 21 plus 6. So after this gestational age, if you are going to start abortion on a live baby, so on humanitarian ground, you have to put actually on her sleep mode before starting this, cruel things. Okay, intracardiac potassium KCl injection is most commonly administered and is the recommended method to ensure the fetal AC sleep, right? And we can do this in, other setups as well, in multiple pregnancies, in, multi-fetal reduction setups, depending on, chorionicity, because never in monochorionic babies, okay? So, Section 9, no emergency risk, right? And Section 10, emergency risk. Like in Section 9, there will be risk to the mother, but it will not be an emergency situation. But 10 will be the emergency situation. 11, there will be a lethal fetal, fatal fetal anomaly, and 10 means on social reasons, okay? And under Section 9, gestational age limit is less than 24. 10, no gestational limit, she can come at 23 or 33 because we have to save her life. For 11, no gestational age limit, because what we will do if baby is having an 𝗪𝗵𝗃, whether at 12, whether at 24 or 34, okay? But for social reasons, remember, in Ireland, this is mandatory. Pregnancy should not exceed 12 plus 0 weeks, okay? And there is a 3-day mandatory waiting period after certification by a medical practitioner. Got it? So remember, if a patient is coming and today her CRL is 63, or she is at 84 day, or 12 plus 0, and she is requesting termination, she can't, because you will wait for 3 days, and after 3 days, she will cross 12 plus 3. So that's why. Got it? So if on Monday she is coming, Tuesday, Wednesday, on Thursday, you will start termination. And at that time, she will exceed the limit. Okay, so 12 weeks plus 1 day exceeds 12 weeks. Therefore, 12 weeks plus 0 is more, crucial timeline. If she is 12 plus 1, no legal termination on social reasons. Okay. So less than 9 weeks, obviously CRL is more important than LMP. As by CRL, if it is less than 9 weeks, we can actually manage her in primary care, and MTOP we can MKIT we can give, and she can, and MKIT usually have drugs including the painkillers as well, including the antiemetics as well. But if her gestational age is 9, between 9 and 12 weeks, then you will terminate her in secondary care in hospital. You will admit her in front of your eyes. You will give her mifepristone, and followed by 48-hour or 36-hour, minimum 24-hour misoprostol. Okay. And maybe she will opt surgical top. So after 9 weeks, she can opt MTOP or STOP. MTOP means medical termination, STOP means surgical termination, any. Okay. And once her CRL crossed 63 or 12 plus 0 weeks, then this is a different legal pathway. Means you will assess her on other grounds of abortion. So again, remember, less than 9 weeks, primary home care, MTOP only, misoprostol taken at home, no routine scan required. No routine scan required. This is your exam question. Why? Why? Because patient is low risk. But if I say patient is having previous salpingectomy, or smoker, or having inflammatory bowel disease, pelvic inflammatory disease, so no, there you will not give her, blindly MTOP for, primary care. No, never. You will do ultrasound first. Okay. So if a patient is low risk even and falling between these weeks, 9 and 12 weeks, then you will start her termination under your observation, means in hospital setting. As per her other indications or her own wishes, she can opt MTOP or STOP. And STOP can be MVA or it can be EVA, manual vacuum or electric vacuum aspiration. But vacuum aspiration is better than short curettage because short curettage will cause more intrauterine adhesions and escharments. Okay. So she will take misoprostol in hospital and ultrasound is recommended. You will see a question in exam here. Okay, when you will do ultrasound in before 9 weeks, when she is not sure of her dates, when you are suspecting ectopic pregnancy, our patient falls as per her CRL between 9 and 12 weeks window. Okay, so you will not do ultrasound if a patient is low risk, less than 9 weeks. Okay. So how you will give her MTOP? You will give her mifepristone, 200 milligram oral. You will wait for 1 or 2 days. Then she at home, the kit you have already given. From kit, she will take the drug, 800 microgram isoprostol. And Irish always give buccal from buccal route. Versus Aisha, as you said, you are preparing for MRCOG part 2 as well. They used to give buccal, sublingual, oral, vaginal, except rectal, all routes, but Irish only buccal. Okay. Please actually make a note of this point. And this single concept solves your, multiple questions later in future in IUFDs and inductions. Okay. And okay, here I will actually give more time. Apology for taking too much time for questions which I can easily skip, but you will actually feel good in your exam. You will feel confident. Okay. So remember, she's at 9 weeks. You have given her misoprostol. Okay. She has taken this drug from buccal route and she will wait for after 4 hours. Okay. After 4 hours, if no bleeding after 4 hours, you will give her another dose. Okay. And how you will confirm? You will confirm her after repeating UPT or low sensitivity. High sensitivity can peak up to 10, I guess, intrauterine international units of HCG, I guess, and low sensitivity up to 40. Somewhere I read, but if as you particularly asking about this, you can search more. But high sensitivity can peak as minimum as 10 international units of beta HCG. Okay. And no, Ikra, if the process has not been started, then she will, after 4 hours, she will repeat. If no bleeding after 4 hours. Usually within 1 to 2 hours, we're expecting she will start to, she has to start bleeding. If she is not starting it, then she will wait for 4 hours and she will take the second dose. But second dose will be 400 microgram. Okay. And she will start bleeding, and then she if no red flag, no heavy bleeding, foul smelling discharge, nothing, no significant pain, not significant pain, obviously moderate pain she will have. So she will experience slowly, lighter symptoms, and she will settle when process of abortion will complete, and she will repeat her UPT at 2 weeks. Remember this. Okay. And between 9 to 12 weeks, you will admit her, you will give her mifepristone, you will wait for 48 hours, you will give her misoprostol again from buccal route, and you will administer 400 microgram every 3 hours. Okay, and maximum 4 doses. So it's slightly different. I will show you more differences. Just wait. So for if she's opting between 9 and 12 weeks, STOP. Okay, So for MBA, only local anesthesia is enough. For EBA, GA is mandatory, and we will avoid basically sharp instruments. And for this, we have to ripen the cervix as well. So pre-evacuation, you will give her misoprostol, and here you will not give her from buccal. You will give her from from vaginal route. So ripening you will do via vaginal on priority, and rest everywhere you will use the buccal route. Okay, and after this you will start the procedures. That's it. Okay, now I'm going to actually show the actual slides from this original guideline. But just remember, before 7 weeks, NTD is not needed. 7 to 9 weeks, if it's a case of abortion, medical abortion, then you will discuss with her. Shared decision will be, recommended. And if patient interested, her blood group is negative and she is non-immune, you will give her NTD. And between 9 to 12 weeks, this is mandatory. This is not like this shared decision based administration. You will give. Okay. So some complications as well. They don't love that much, but remember, even with MTOP, more chances of ongoing pregnancy as compared to the STOP. So STOP is more effective and successful and more, predictable. Okay, infection approximately same, but in STOP there are more cervical lacerations and perforations. And perforations up to can be 1 to 4 among 1,000. Just remember this 1% for this exam. And in STOP, obviously, you have to give antibiotics. Not in MTOP, but in STOP, antibiotics are recommended. VTU assessment is mandatory because she is pregnant. So, like we know, in every patient who is pregnant, VT's assessment is mandatory, whether she is opting MTOP or antenatal care. Okay, and you will discuss her STI testing as well before STOP, or you can, just counsel her if she is not opting. And obviously, you will discuss her contraception. Okay, so these are important points. If patient gestation age is 12 plus 0, it is the absolute legal cutoff. You will not start social termination. Remember this CRL. Remember this 3-day mandatory waiting period. Remember this routine scan. Remember this post-termination scan things, because after termination, we don't do ultrasound. We do to check the completion only low sensitivity urine pregnancy test at 2 weeks. Okay. And NTD, remember, before 7 weeks, not needed. 7 to 9, shared decision. And after 9, you will give 250 international units. And counseling is important. Okay. So again, you can see compilation of everything before 9 weeks, 9 to 12 weeks, and after 12 weeks, what you should do. Okay. So let me know, patient is at 12 weeks. By scan, she is 11 plus 1. She came for termination of pregnancy because of social reasons, or under section 12 she is coming. So what you will do? You will give her mifepristone. You will refuse her for termination. You will start termination immediately after assessment by 2 registered medical professionals. I will explain everything, no worries. I am reading your chat box. I'm not ignoring your questions. I will explain, no worries. So first of all, just let me to complete this interim guideline. Then I will explain what is 3-day mandatory rule, okay? So what you will pick? So by scan or by CRL, she is 11, so we can start. Why we should refuse? And why we should give mifepristone after 3 days? The maximum we can wait for 2 days only. And after this, we have to give misoprostol, right? And she is coming here. We have not started anything because we actually have to complete the documentation by 2 medical practitioners. So option C is only possible key. Okay. If you are agree, let me know. Give me thumbs up, then I will move. Yes. Okay. This is your recall question. And next, continuation of pregnancy occurs following MTOP. And due to a delay in recognition, the pregnancy has progressed. And crossed 63 mmCRL. So what you will do now? Due to some delay, but delay has occurred. Whoever was the culprit patient was actually slow, or system was slow, but CRL has crossed more than 63 ml. So what you will do? You will provide one more a course of mifepristone. You will start as top, or you will say that termination can't be done under this section. No. Read here, where they have said that this is a case of incomplete miscarriage. Only if it is a case of incomplete miscarriage, and they will say that she is bleeding heavily, her OC is open, only then we will complete the process. Otherwise, we will not. So option is C. So if you can't see anything, it's mean it is not there. Do not assume it. This is a case of incomplete miscarriage. It will be the case of the incomplete miscarriage. It will be there. So if anything is buzz, it will be visible. They said this is a delayed recognition. Pregnancy means it's not POCs, it's a pregnancy. Okay, got it? Give me thumbs up if you are comfortable with option C, and then we will move. Okay. So friends, in primary care setting, persistence of pregnancy symptoms for more than 5 to 7 days after MTOP or failure to pass expected pregnancy tissue would be suggestive of ongoing pregnancy. And women should be advised to contact their provider and referral to the secondary care we can consider. So this is my own exam question. Patient has started, actually she was at 6 weeks. She started MTOP in primary care setting. Pregnancy was, symptoms were persistent. So they were asking where you will refer her, towards primary care provider or towards secondary care provider. So we will first refer her towards back to the primary care provider. And if they need, they will refer her. They will consider to refer her in secondary care or, in hospital. Okay, clear? However, if the same patient, whatever his gestational age, she has started MTOP, and MTOP has been provided by a primary care setting, but she is having red flags like severe pain, she collapsed in her home, heavily bleeding, her pulse is rising. No. In that situation, you will not refer her towards the primary care. Primary care don't have OTs and resuscitation things. If any red flag, then directly refer her in, those setups, those have, resuscitative measures, and they usually have wound on in secondary care or in tertiary care. Okay. So if continuation of pregnancy occurs following MTOP and due to the delay in recognition, the pregnancy has progressed beyond 12 weeks, 84 days from LMP or CRL 63 or more, then despite the potential teratogenic effects, it's not legal to initiate a repeat termination process. In such cases, non-directive counseling should be arranged and options to avail of TOP in other sections discussed. So we have already discussed. Okay. So I think now you are very clear. So very good flashcards before 9 weeks, 9 to 12 weeks, and after 12, what we should do. Okay. So in secondary care, we can go for surgical, but never in primary care. Okay, never in primary care. And after this, when to check pregnancy after MTOP? After 2 weeks or 14 days. By low sensitivity UPT, not 3 weeks, not 10 days. And I already actually advise you bring a piece of paper and keep noting follow-ups there. Make your one-liners, because in these sessions you are going to actually read a lot of follow-ups. Okay, a lot of follow-ups. So, woman has ongoing pregnancy symptoms are a positive low sensitivity urine pregnancy test following early 𝗪𝗏 in primary care. So, what you will do? Because she is not having red flag, she will refer her towards primary care, termination provider, right? And if you will not, and after when I was appearing an exam, in the next attempt, actually the key was not this. In option they have not given this. It was 𝗵𝗔 was there. Okay. So 𝗵𝗔 may be repeated after 48 hours. You can have idea if pregnancy is really going on, so it will double. It will be more than 66, or it will be dropping more than 50%. Its pain, it is going to fail. A referral to secondary care if not negative or declining. Okay. Like 𝗵𝗔 trend is not going to slow down, or again, irrespective of this, it's rising. Or if patient develop any red flag, then you will refer her to in secondary care. Is that clear? Is that clear? This is your recall. Definitely you will read this question, and whenever you will read with whichever mentor will be that, whichever course will be that, you will remember me. Ma'am told us the correct pathway. Okay. So, like option A is our key. We will refer her in primary care termination provider. Okay, option A. Husna. So, actually, let me to clear one thing. In primary care setting, our main aim is that if pregnancy is ongoing or anything is abnormal, to exclude the ectopic pregnancy. Okay. And we will do ultrasound if, like, they have referred her to primary care setup. What they will do? They will do her ultrasound, and on follow-up, if feasible, or ultrasound is not available, they will do her serial 𝗵𝗃. And if a TVS or serial 𝗵𝗃 is not available or feasible, then they will escalate and refer her to secondary care. Okay? Be very careful. With this concept, you are going to solve a lot of questions. When to do ultrasound, and when to do serial 𝗵𝗃, and when to escalate in primary care. And in secondary care, ensure complete termination is our aim, because at this timeline, a lot of ectopics has already excluded, because this is not that gestational age where we will see ectopics. Okay. So visual tissue after expulsion is mandatory. Either patient will check and explain and will bring that tissue towards us, or if she is already admitted, then staff will make sure that complete expulsion has been occurred. And if any uncertainty about expulsion, okay, then you can do ultrasound. Okay, then you can do ultrasound. And on follow-up, no scan if patient is asymptomatic and visual confirmation actually has been done. Okay, we will not, on follow-up, we will not do ultrasound if we are sure that she has completely expelled the products of conception. Okay. And when we will escalate in secondary care settings, we can escalate if it is in incomplete miscarriage. And incomplete miscarriage can be after 𝗪𝗏 or 𝗪-stop. You have seen a lot of cases. After 𝗪𝗏, patient still having some POCs, and you have to convert into 𝗪-stop. Or even after 𝗪-stop, patient still comes with remaining RPOCs. Okay. And last one question. Surgical complications. What is the recommended approach to management of a uterine perforation in a woman undergoing 𝗪-stop? So remember, this patient is pregnant. So if you are suspecting perforation, then laparoscopy is the investigation of choice. This is the primary actually investigation. You have to do laparoscopy. However, this is not very immediate. Very immediate, you will catheterize her, you will give her antibiotics, you will involve your consultants. But ultimately, you have to do this primary intervention if you are suspecting uterine perforation. Okay? So remember this. The risk of uterine perforation with surgical termination is approximately, I told you, remember this complication, 1 to 4 in 1,000 cases. It most commonly occur at the time of cervical dilatation. For first trimester as top, this is exam question. At the time of dilatation, we wrongly, enter into the cavity and we actually commit perforations. And with the use of forceps for evacuation in second trimester surgical. So in first trimester at the time of dilatation, because cervix is very hard, and in second trimester at the time of actually by when we are using the forceps for evacuation purpose. Remember, if the woman's status or findings during laparoscopy suggest damage to the bowel, blood vessels, then you have to actually consider laparotomy conversion as well. Okay? Very important. So in surgical top, you will see cervical lacerations and uterine perforations. And what is the sign of uterine perforation? Sudden short pain, instruments pass too easily, loss of normal resistance, or gritty sensations, or fat you are coming through the tissue. So fat, it's not fat, it's basically momentum. So you have basically crossed the uterine wall and perforated it. And you are coming up with now not POCs, but rather with momentum. Okay. So management is laparoscopy, it can be laparotomy, but for sure under MDT care. In cervical laceration, remember, and after LETs as well, we will see this question in gynecology as well. If tear is small, it will resolve with compression. But if it is more than 1 centimeter, then you have to suture it. And maybe if high cervical tear, which are extended into the lower segment, then you have to, go for, more extensive surgeries. Okay. Next, what is the recommended approach for pain relief for MTOP? We can give ibuprofen and we can give PCM as well. Okay. For infection, but we will do this in exam question as well. They were asking when you will give oral and IV. So remember, in primary care setting, if mild infection, no sepsis features, you can give oral antibiotics as well. Okay. And if you are suspecting infection in secondary care settings and our infection is severe, then you have to give IV fluids and IV antibiotics, specifically broad spectrum. And it is best practice to recommend administration of NSAIDs in the absence of any medical contraindications before misoprostol. Use of heat applied to the site of pain can also help. Okay, you can give paracetamol as well, but NSAID is more strong painkiller if no contraindication. And I told you people that in perforation, whenever you are doing surgical top, you have to do laparoscopy. But this is, primary treatment. Immediate is that you will alert the team, you will catheterize her, you will give her antibiotics, you will call your senior. Okay. If small perforation, you can keep it as, or you can repair. But if it is large and difficult to repair, then do the laparotomy. This is TOG article of uterine perforation. And I think now we should start doing the papers again. We will revisit these slides later with the questions, okay? So you were asking what is 3-day mandate waiting time. For social abortions, in Ireland, this is recommended that before starting the procedure of termination, patients should wait for 3 days. Okay. So here we are. We have done this question. Okay. Yes. No, we have not done this question. Now we are doing. So question number 3, a 31-year-old patient, 𝗪𝗶𝗹𝗪 presents at 14 weeks of gestation by dates with heavy bleeding, residual clots and grape-like vesicular tissue. She has vomited persistently for the preceding 3 weeks and she has lost 5 kg. On examination, she is pale and calm. Pulse is 122, blood pressure 92, beta-HCG. Look at the beta-HCG in thousands and look at the gestational age, 22 weeks. At 14 weeks, we are here at 22 weeks. And on ultrasound, there is no sound appearance. So this is complete mole. Okay, we know this is complete mole, but look at her vitals, her pulse, her bleeding. So what will be the ideal key? Because this is a complete mole, ideal treatment is suction evacuation. A out, C out, D out, obviously E out. What left? B, and B is ideal as well. She needs resuscitation. We have to cross match. We have to start suction evacuation after pre-op fulfillments, and everything we have to do under specialist care, and we have to notify the trophoblastic center as well. Okay, so this is, I told you people, molar ectopic questions are very straightforward. Only miscarriages and termination laws will be, give you some headache in exam. Okay. And another question, 22. This is not question number 82. Basically, this is your recent MRCPI March 2026 paper. So I have screened all early pregnancy questions from this. So it is question number 82. But for us, it is question number 4. Okay. Maybe question number 80 will be on oncology. Okay. But we will do today only on early pregnancy related questions. So this is the patient and she is coming in emergency department and she is actually coming here in collapse state. 8 days ago, she was prescribed mifepristone and misoprostol for medical termination of pregnancy at an estimated 6 weeks of gestation in primary care. And we know in primary care, there is not needed to do the ultrasound. Without doing ultrasound, we can start MTOP. Okay, so there will be less actually hospital-based burden. But rarely it can be a surprise ectopic, the same we are going to face here. So here you can see that on assessment, she was low risk. But because she has, she was in primary care, and in primary care, we don't do initially any ultrasound. So we have not performed it. And she reports that she had only minimal bleeding since after this. And on arrival, look at her pulse, 132, her BP 78, cool peripheries. Basically, she's in shock. Her abdomen is distended and diffusely tender. Why tender? This is acute surgical abdomen with gording. These things we see in appendicitis and in ectopic only. Okay. And there is a right shoulder tip pain because there is hemoperidoneum inside. And if it is positive because she is pregnant, okay. What is the most important diagnosis? To exclude septic retained products. No, this is not look up septic. In septic miscarriages, we don't actually see this tenderness, like we can see tenderness, but gardening acute surgical abdomen is not feature of septic miscarriage, okay? And neither they have mentioned anything on her temperature. Then ruptured ectopic, yes, this is ideal. Uterine perforation, we have not done any intervention. So why? So it can be perforation if we have done intervention, but no, we have not done any intervention. Amniotic embolism, concealed hemorrhage for an incomplete miscarriage. So all options are very, close, but not ideal. Ideal is only one, and you will agree. This is the topic. Okay. So this is the topic, and this was tricky question for a topic. A 29-year-old patient at 7 weeks with mild titral pain and bleeding. And earlier she underwent a left salpingectomy 2 years ago for a ruptured left-sided ectopic pregnancy and has no other triple pathology. And she is stable with soft, tender abdomen. TVS shows that she is having empty cavity, but at right adnexal mass has 26 mm sac with no FCA, no free fluid. Serum beta-HCG is less than 3,000. So when serum beta-HCG is less than 3,000, SAC is less than 3, no FCA positive, everything is labs are normal. So everything is going towards the This is for sure ectopic pregnancy. Okay, ideal situation of actually C option, systemic metho-IM. Okay. Okay, so coming forward, a 30-year-old patient grabbed a 𝗏𝗏 and she's having a single intrauterine sac with main sac diameter of 21 and a yolk sac is present, but no embryo or fetal pole is identified and there is no fetal cardiac activity. Both adnexes are normal and there is no free fluid. What is the most appropriate management? So, okay. See, if they are saying this is an intrauterine pregnancy, so in intrauterine pregnancy, what are the possibilities? Either it will be the normal viable pregnancy or it will be the missed miscarriage. Okay, and if her CRL is more than 7 on or equal to 7 on TVS or more than 8, it's not actually equal to 8, it's more than 8 means 9. Okay, on TAS, then it will be missed miscarriage. And they said there is nothing, no FCA, so it's mean it's not normal. So neither it is normal, neither it is missed, so it is basically pregnancy of uncertain viability, right? So SAG is less than 20 or equal to 25 mm and CRL is equal and less than 7. It's mean this is a case of pregnancy of uncertain viability and we have to repeat her TVS after 7 days or after 10 days or after 14 days if we are repeating on TAS. Okay? So, ready for next question? So, give me thumbs up if you are ready for next question. So, we have to repeat it after 7 days. Okay? So, just wait. And I want to actually give you another flashcard here. And what this flashcard says, see here. Can you see? So on TVS, if fetal pole with a CRL equal and more than 7 with no FCA, then this is the fulfilling the diagnostic criteria of missed miscarriage. Okay, if it is less than 7, then this is pregnancy of unknown viability. And for SAC, it should be equal and more than 25. Okay. And for TES, it's not like this. It is equal to 8. It should be more than 8. If I will say the patient is coming with the CRL 7, it's missed miscarriage. If it is coming with CRL 8 on TVS, it's missed miscarriage. Okay. Sure. And if I will say on transabdominal ultrasound, if patient is coming with CRL 8, is it missed miscarriage or pregnancy of uncertain viability? What is this? This is important because in exam you will actually not appreciate the difference equal and more than 7 and less than 7. Trust me. So remember, if it is 8, it is pregnancy of uncertain viability. If it is more than 8, then this is missed miscarriage if you are doing transabdominal ultrasound. And fortunately for SAC, whether you are doing TVS, whether you are doing TAS, the SAC diameter is same. 25, this is missed miscarriage, and obviously after this. Okay? Yes. Yes, you are right. So remember this difference. And just 1 minute. Okay. See this slide. This is a very beautiful flashcard that if mean sac diameter is less than 25, you will repeat because this is a case of PUV. Okay, but it is 25 or more than 25, then this is a missed miscarriage, and I'm talking about the TVS. Okay, and same for CRL 7 or more than 7, then it's mean this is a missed miscarriage. And if it is less than 7, no heartbeat, then repeat her scan. Okay, and for TAS it should be more than 8 for missed miscarriage. Okay. Okay, now we are doing another question. Okay, so we have done this question number 85. Give me thumbs up again if my PPT is visible, girls and boys. Okay. So see, after attending this session, I told you people you shouldn't be worried about your theory revision. Okay. So next is yes, we have just covered it. Next is a 34-year-old patient. She's 𝗪𝗶𝗹𝗪, attends the recurrent miscarriage clinic with her partner, and her most recent was at 9 weeks following a confirmed fetal cardiac activity. Her cycle are regular, her BMI is okay, no personal history of thrombosis, pelvic scan is normal, both partners are phenotypically normal. So which of the following is the most important cause of her recurrent miscarriage? You can guess it for me. Can you? So everyone is saying APLS and everyone is very wise because they have asked most important. Okay. And can I ask what is the most common cause in first trimester miscarriages? So you are right. 50% this is chromosomal issue. And among chromosomal issues, they are the trisomies and they are autosomal trisomies. Okay. And what is the most common cause of a recurrent miscarriage? You said chromosomal problems. Saprodic, they are trisomies, and in saprodic, they are autosomal trisomy. But in recurrent, they are balanced translocations or reciprocal translocations. So saprodic, autosomal trisomy, and in recurrent, there are balanced, still trisomy, but there will be the balanced translocations among parents and unbalanced in fetus. Remember? This is very basic question. You remember this from your graduation. Okay, so they asked important, treatable, significant. This is always APLS. Okay. Next, yes, APLS. A 29-year-old patient 𝗪𝗶𝗹𝗪 para 0 attends the early pregnancy assessment unit having sustained saprodic first trimester miscarriage. And on scan, it was actually intrauterine pregnancy and, with no FCA. So it was missed miscarriage and, ended at like this at 8 weeks. She has no relevant medical history. She and her partner are distressed and ask what caused the loss and whether they did anything wrong. So what is the most common cause of saprodic first trimester miscarriage? Embryonic chromosomal abnormality or parental chromosomal abnormality. Problem can be inside parents, the problem can be inside fetus. Why Tikra? Why C? Why C? What is actually important buzzword for C? Okay, गलती हो गई. It's okay. So Aisha says A. So friends, whether it is saprodic miscarriage, whether it is recurrent, embryonic or fetal chromosomal abnormalities are more common. Whatever is the pattern, autosomal or reciprocal, okay? Okay, so 26-year-old patient, 𝗪𝗵𝗹𝗪, she is here in early pregnancy assessment unit at 8 weeks by dates, and she is having light renal bleeding, and she is having lower abdominal discomfort. She is stable, soft, non-tender abdomen, no cervical excitation. TVS performed 48 hours ago, and there is no intrauterine sac, no adnexal mass, no free fluid. Beta-hCG is 3,000, and later after 48 hours it is 32 and 70. So what is the most appropriate next step? Yes. Yes, 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 yes. You have to. Okay, sorry for this delay. Acha. So where we were here. I want to actually searching this table for you people. This is a case of obviously pregnancy of unknown location. And initially we were here. Patient came to us. We did her actually we saw that she is stable. Okay, and we did her serial beta-hCG after 48 hours, and one was 3K and one was 32. Okay, 100. So with this trend, we have to analyze that how is the pattern. So remember, if rise is 66 or more, this is a case of likely intrauterine pregnancy. You have to reassure her, you have to counsel her that still ectopic is possible, because few ectopics do rise like 66, specifically Carnwell. Okay. And you have to repeat her TVS after 7 to 14 days or earlier if her beta-HCG is more than 1500. Okay. Anytime on serial follow-up. Got it? And if her rise is, if her drop is less than 50%, right? So this is likely a miscarriage, right? So we have we have done her one beta-HCG, and after 48 hours we have done her second beta-HCG. So if her second beta-HCG is less than 2000, so we will advise her to repeat her UPT in her home at 2 weeks, right? But her second beta-HCG was more than 2000, so we will advise her to repeat her again in next 48 hours. Okay. And if her beta-HCG is 50% decrease in the third beta-HCG, so what we will recommend her? We will recommend her that she can repeat her UPT in 2 weeks, as they said earlier. But her drop is less than 50%, specifically when her beta-HCG was 2000 more on third time repeat. So we will discuss with her with this case with our senior. Okay, you have done this algorithm with me in your theory course as well, and I am revising it again because definitely one mandatory question is coming up. In my exam, I was somewhere here. Okay, but every question which I have given a yellow card, this is exam question. So either it will be 66% rise and it will be likely intrauterine pregnancy, either it will be drop more than 50%, it will be likely a miscarriage. So if it is not rising optimally or not dropping optimally, then we are here. Then we have two options. It is actually high risk PUL, or it is low risk PUL. Right? High risk PUL means drop is less than 66 and rise is less than 66 and drop is less than 15. Okay. However, if her drop is more than 15%, then this is, low risk PUL. So if drop was more than 50%, it was likely a miscarriage. If drop is more than 15%, then this is low risk PUL. Okay. So with drop word, remember these two things. More than 50% drop, likely a miscarriage. More than 15% drop, this is not likely a miscarriage. They are saying this is a low risk PUL. Okay. Okay. So what we will do if patient is having low risk PUL? If patient is having low risk PUL, we will repeat her beta-HCG not in 48 hours, rather in 7 to 14 days. And if she is having high risk PUL, we will actually suspect here ectopic and we will repeat her serum beta-HCG in 48 hours. Okay, this is very important, and we will discuss with senior as well, and we will do her early TVS if her beta-HCG is more than 1000. So you have to remember every question. And I remember one question as well. A patient was coming with PUL, because her UPT was positive and she was having mild pain, right? So, but she was hemodynamically stable and TVS showing that there is no pregnancy. So basically this is a case of PUL, right? But what we should do, obviously we should repeat her for beta-HCG here, everywhere. But if you will feel the difference, if patient is having pain, then you have to admit her. And if she is not having pain, then this is not important. You have to admit her. So in exam, there was a choice as well. Admit and repeat her beta-HCG. And one was this, just repeat her beta-HCG after 48 hours. So what you will opt if a patient is hemodynamically stable but with pain, with PUL? Admission is better Isn't it? Give me thumbs up. Okay. So now coming towards another trick. How we will come to know that patient beta HCG is rising 66 or not? How? In 2026 recent exam, they said first beta HCG is 3000, second beta HCG is 32,000. So what you have to calculate basically, I'm giving you some actually calculation hints, and you can easily do it in exam. This is not simple, Safia. You can't do it. You have to do it the way I'm doing it. What is your original value? This is 3000. You have to multiply it 1.6. Everyone go open your calculator. You will have calculator in your exam as well, built in your system. Let me know. Multiply 3000 with 1.6. It is rising. We want to know it is rising 66 or not. Common sense says it is not rising as per 66. I know, but I am just advising you, you have to learn calculation as well. But because in exam, you can see a very borderline calculation. You will think it is more than 66, but it will not be. It will be exactly at 65. So learn this, please. So it's not actually normal intrauterine rise, because if it would be, then the second value should be 49 something, but we have 32. So it's mean it is not rising 66%. So this is a high risk PUL. Got it? And what we have to do in high risk PUL, senior involvement and another beta HCG. And earlier, if the second beta HCG is more than 1000, we can do TVS then. Clear? Yes. So what will be our key? What she need? Ideal key is senior input. Ideal key is earlier TVS, because second beta HCG is more than 1000 and here it is 32. But stepwise, first thing is senior involvement, then third beta HCG after 48 hours. Then if third beta HCG is more than 1000, we can do early TVS. Okay? So this is my humble advice. Whenever you are free, learn to actually this algorithm a lot of time. Okay? So again, stepwise, I am revising you people. We are here. She is a case of high risk PUL. We are suspecting ectopic pregnancy here. We will repeat her serum beta HCG in 48 hours. We will discuss with the senior obstetrician gynecologist. We will consider timing of the next TVS in 7 days when serum beta HCG will be more than 1000. Which serum beta HCG? Third one beta HCG, which we have repeated here. If it is, let's assume 1200, we can repeat her TVS there and then, or we will wait for 7 days. Here they have written R. You can find a question from here as well. Trust me. They love this algorithm that much. They will give you the patient who has, come our, okay, like the patient who is coming with her first beta HCG is 3000, second beta HCG 32,000. TVS is showing no intrauterine and extrauterine pregnancy. You are suspecting PUL, but you are suspecting high risk PUL. Means you are suspecting possible ectopic until proof otherwise. So what you will do? You will do her third beta HCG. So if her third beta HCG is 34,000, so what you will do? You will involve senior. What you will do? You will do her TVS. When you will do her TVS? Either after 7 days or now as well, because it is more than 1,000. Now clear? So they will give you a lot of options. I told you people come with, your notebook and write down the follow-ups. In which conditions you have to repeat low sensitivity UPT, high sensitivity UPT at 2 weeks, at 3 weeks. Somewhere you don't have to do anything. Somewhere you have to repeat TVS. So many things. In early pregnancy, you will see, they are playing with us with TVS and with beta SCG and with timing as well. So now moving forward. Apologies for actually taking your precious time, but I believe these are very tiny, minor things. And if you are not revising them with me in that way, then you will face difficulty in exam. So we will repeat her beta SCG, okay? Option B. No. We will repeat her. Option A is our key, isn't it? This is our key. And third, if it is the third one, then we will do the TVS. Okay. I don't know what was in exam. It can come in that way as well. Let me to make another question for you people. Like, so what you will do? You will not do fourth TVS, fourth bit SCG. You will do repeat. And you can see repeat now. Or you can see, of course, like cleansing, like option F. Repeat after 7 days, and definitely many will do this because they will not understand that like third one is more than 1,000, so they don't have to wait for 7 days. The option will be better. Yes, now. Okay. Okay, so this will be our key. So now question number 88 we have done. Now 17 question. A 33-year-old patient grabbed a 4 and she is under care of a recurrent miscarriage clinic following 3 consecutive first trimester miscarriages. In Ireland, the recurrent miscarriages should be consecutive. Okay, Aisha, as you are preparing for MRCG 2 as well, so you should know this difference, because in GTG, they can be non-consecutive, but in Irish, they should be consecutive. Okay. And in GTD, there should be 3 universally and 2 in risk factors. But in RCPI, they can be 2. And if patient age is less than 35 or more than 35, then they can be 2 or 3. I will show you later. So recurrent miscarriages definition is totally different versus MRCOG. Okay. Anyway, so as they are saying recurrent, so it's mean they are consecutive as well. And she has done her APLS antibodies, they are normal, her investigation has been done, and she is classified as unexplained. Now again, her UPT is positive, she is coming at 6 weeks. And now she's reporting light vaginal bleeding for 2 days as well. Transvaginal ultrasound confirms single intrauterine sac with a yolk sac and a hole with FCA. So what is the appropriate management? So what we do in recurrent miscarriages, this is very important. Now you have to revise recurrent miscarriages with me. Okay, before starting it, just pick your key here, then we will move. So folic acid, this is very, low yield question. In exam, they will not ask you for folic acid, trust me. Okay, if anything is low yield, it is not going to be judged in your exam. So low dose aspirin and vaginal progesterone 400 milligram. Aspirin we can give in recurrent miscarriages, okay? And as patient is having threatened miscarriage, so we can add vaginal progesterone as well. So B is better. Why heparin? No need of heparin because APLS workup is negative. Prednisolone and immunoglobulins are need. So you can easily pick the right key. This is B. She need allopurin and she need progesterone. So now we will revise the recurrent miscarriages. Okay. So in Ireland, yes, this is a recent guideline, Irish guideline. They said 2 consecutive first trimester miscarriages are required for recurrent miscarriages definition. If no previous pregnancy extending beyond 24 weeks, then it is primary, and if they have previous pregnancy, then this is secondary. So in MRCPI, consecutive miscarriages do not meet the Irish definition, but still merit. You already know this. They should be consecutive in Irish and non-consecutive in like GTG. Okay, required 3 or more. They should be non-consecutive or consecutive, whatever. And ASHA requires 2 or more losses. Doesn't mandatory. They should be consecutive, non-consecutive. But in Ireland, requires 2 consecutive first trimester miscarriages. Okay, and if patient fulfilling the criteria of this, then we have to evaluate her. What is the cause? Okay, if it is unexplained, unexplained, what we should do, and if it is explained, what we should do. So remember that if it is explained and because of APLS, so we have to give her aspirin before conception or suitably at the time of conception. And when pregnancy test is positive, we will give her heparin. And obviously, if she's having some kind of bleeding or threatened miscarriage, then we can add vaginal progesterone as well. Okay. If a patient who is having recurrent miscarriages as per Irish recommendations and having threatened miscarriage as well, so we will give her allopurin, heparin, and vaginal progesterone. 400 microgram twice daily. Okay, and vaginal route, micronized. So APLS treat with aspirin and heparin, thyroid treat with levothyroxine. If you're trying septum because of septate uterus, you have to consider stereoscopic septum dissection. And if chromosomal abnormality and it is unbalanced translocations, then you will refer for genetic counseling. They can consider ART techniques or they can consider natural conception. But in both conditions, outcome is same. Okay. And if it is unexplained recurrent miscarriages, means no cause you have found. So what you will do as per Irish, I will tell you later. So mandatory workup is that you have to do in every patient with recurrent losses, full blood count, TSH, TP antibodies, 𝗪𝗵𝗃 only if clinically indicated, not a routine. First 3 are in every patient and last 1 if indicated. And APS screening in every patient with 3 antibodies: lupus anticoagulation, anticardiolipin, and B2 glycoprotein. Lupus anticoagulation is strongest actually predictor of recurrent miscarriages. Okay. And APLS is the only thrombophilia routinely screened because in inherited thrombophilia, they don't screen. With this, they screen TSH, T4, TP antibodies in every patient, okay, with CBC, and 𝗪𝗵𝗃 only if indication. And if patient is having uterine anomalies, so initial test is TVS, ideal first line, best is 3D, and if no conclusion after 3D, then MRI. Okay. However, this recent guideline says you can consider ANA. You can consider if patient is having hyperprolactinemia prolactin test. You can consider histopathological review, obviously for karyotyping. Okay, so they are very important. So if her age is less than 35, 2 consecutive miscarriages. Okay, and if her age is 35 or more, then add 3 consecutive miscarriages. You have to send karyotyping, fetal karyotyping by actually array hybridization techniques, and if not available, then parental karyotype. Okay, if not available, then proceed to the parental karyotype. So remember, less than 35, 2 consecutive miscarriages. And after 35, at 35, 3 consecutive miscarriages, you will send her the products of conception. First miscarriage, you will do nothing. You will provide supportive care. Second consecutive miscarriages, you will initiate the investigation, some in blood and some in, imaging. So in blood, you will send antibodies, thyroid test, okay, karyotyping test, and you run some imaging tests like TVS or septum identification. If no cause is found, then you will label that this is a case of unexplained recurrent miscarriages. Okay? What we will do in recurrent miscarriages, because patent or unexplained, we can add progesterone. Okay? So this is the guideline, everything I have mentioned. 2 consecutive thyroid, FBC, means CBC, and APLS workup, and we can consider HbA1c. If age is less than 35, after 2 consecutive miscarriages, we will consider cytogenetics on pregnancy tissue. And if age is 35 or more, then after 3 miscarriages, we will send karyotyping, okay? And actually there is a very, short time. The recurrent miscarriages they have published in 2023, then quickly after 1 year, they have published another one. Okay, so remember, they love this differences is because earlier there was no specific follow-up if patient is having positive TPO antibodies. But in 2023, if patient is having positive TPO antibodies, even then if she's euthyroid, you have to follow her. Okay, we have to follow her with TFTs at 12 weeks and at 20 weeks. Routinely, ANA was not recommended, but in 2025, we can consider for SLE workup, like we can conduct ANA. Levothyroxine, we can treat. Obviously, overt frank hypothyroidism, we will treat, but we can treat in recurrent miscarriages moderate subclinical as well. Moderate means 4 more than 4. Alone or with TPO antibodies. Okay, alone TPO antibodies, what we don't treat, we treat basically subclinical hypothyroidism with or without antibodies. Okay, and our aim is to keep her TSH less than or equal to 2.5. And recording aspirin. In recurrent miscarriages, if they are unexplained, we can give them actually aspirin, may be considered, but never heparin. Heparin only if it is APLS. Remember this. Heparin only if it is APLS, we can just consider aspirin prior to conception, that's it. And if patient is having bleeding, we can add progesterone as well. So frankly, giving proloprin and progesterone in unexplained cases, you will see, a lot of ideal keys. Okay. So here you can see threatened miscarriage, complete miscarriage, and miscarriage definitions. No, we will cover recurrent miscarriage questions. Okay. So read it. Everything is normal and she is bleeding. So it makes sense giving aspirin as unexplained, and as she is bleeding, we can add progesterone, and we can give progesterone without bleeding as well in unexplained recurrent miscarriages. Clear? Give me thumbs up if you can understand recurrent miscarriages now. Okay. So now question number 21. A 36-year-old patient, 𝗪𝗏 3, is referred following 3 consecutive first trimester miscarriages. Look at her age. We know at 35 or more than 35, she needs 3 consecutive miscarriages so that we can send her products of conception for karyotype. Okay, remember this. Do not mix up, like if I say that at this she's having 2 first trimester miscarriages. So you will think here you have to send no. 2 miscarriages if her age is less than 35. 3 if her age is 35 or more. Okay. Cycle is regular, BMI is okay, no personal history of VT, partner is well, no living children, pelvic ultrasound is normal. What is the most appropriate next step? Yes. 3 consecutive miscarriage is age 35. So they are asking the next step, appropriate, not asking the significant one, treatable one. It will be APLS then. So you people are right. Okay. So it is A. Okay. It is A. Okay. Pelvic ultrasound is normal. Okay. So TV is not needed. And basically, I am not happy with this key. What do you say? 3 miscarriages. Look at her age. And most appropriate, it should be parental karyotype. We can consider. Okay. Thing is that we can consider to send, because the first thing was that to send the fetal karyotype. That was recommendation. And we can consider if they are not available. So C is also okay. But option A is more actually strong. Option A is still, because this comes with more strong recommendation in Irish and even at GTG. Okay. So option A is also good. Option C is also good. But pattern is of this that no previous miscarriage. I can't be sure here, to be very honest. But go back towards the guideline, because we are very close with 2 options. So they said here, okay, her age is 36 and 3 consecutive miscarriages. We have to perform cytogenetic analysis of pregnancy tissue. And if no tissue are, then we have to perform parental karyotype. So she is here as well. And after 2 consecutive miscarriage, she is here as well. Okay. But if you are following the wording exactly is coming from this part. She's exactly 35 plus. She's exactly with 3 consecutive miscarriages, because for 𝗪𝗵𝗃𝗪 World Cup, it's not important that she should be 36. She can be 30-year-old. She can have 2 even. So as per wording, the appropriate is karyotyping. What do you say? So as the option A is also okay. So I'm just checking the chat box. World Cup first, as they have not mentioned no fetal tissue available. But at the same time, they have not given any clue for APLS as well. But rather, they have said no history. Okay, family history means no hereditary thrombophilia, but this is acquired one. So in my opinion, most appropriate word will go, okay, this is an individualized condition, to be very honest. Appropriate word is individualized word. We can't actually quote it with a specific guideline. Guideline always says individualized. So appropriate is that where we we are going to investigate, we can treat as well. Okay. So in case of karyotype, yes, we will investigate. This is linked with first trimester miscarriages, and there is no actually fruitful treatment. But if we are investigating APLS, there is fruitful treatment as well, which can ensure 90% success rate. So on priority goes with APLS workup. Okay. And yes, option C is also okay. So I will actually individualize it, and it is very close, and it's possible. In exam, you can face such very close questions as well. So you can make real-time clinical guess, and I think the most beneficial will be doing APLS workup, okay? And for sure, later we will do her karyotype as well. And patient is 27-year-old, 𝗪𝗶𝗹𝗪. So what do you say? Give me thumbs up if I am opting APLS because they said appropriate, and appropriate means that we have effective treatment as well. Because for if she's having reciprocal translocations as well, what will do? If even if we are not treating, still she has the same actually success rate even without treatment. Okay, so if they said most common workup to rule out the most common cause, then for sure we will go for karyotype. 27-year-old patient, 𝗪𝗶1, pregnancy of unknown location, beta-acid 32, and 𝗪𝗵𝗁 plateaus means suboptimal rise. Okay, and repeat TVS shows empty cavity. Okay, and a 22 mm left adnexal mass separate from the ovary. This is basically ectopic pregnancy, and because 22 and patient is stable, but her beta-acid is 32. So after 3,000 and before 5,000, you can do either, anything. You can treat her medically, and you can treat her surgically as well. Okay. So as patient is not having any significant pain and she is very perfect, her RFT, LFT is okay. So 𝗲 is better. Now coming towards this question, a patient is having 28-year-old patient, soaking 2 pads per hour, passing clots together with an offensive discharge. I think we have covered it, and it was C, resuscitation and clots. Okay. 21, I think we have covered it, and it was repeat beta-acid, and now yes, embryonic chromosomal we have done. Yes, 7 weeks with light bleeding. Okay, we have not done this. This is the last question, no worries, of this year. A 34-year-old patient with 2 previous sections. She's at 7 weeks gestation with light vaginal bleeding. TVS shows an empty uterine cavity and empty cervical canal. But a sac is impacted into the anterior lower uterine segment at the site of previous cesarean section, with minimal myometrium between the sac and bladder. So when cesarean scar ectopic is between the sac and bladder, it is an exogenic cesarean scar ectopic pregnancy, R type 2. Currently, she is, early. She is at 7 weeks. They have not mentioned anything like beta-acid, okay, but she's stable and she wishes to preserve her fertility. So what is the better one? So everything is going towards the conservative, less aggressive option. Okay. So some say C, systemic 𝗲. Systemic 𝗲 has poor success rate as compared to the actually local 𝗲 in cesarean scar ectopic. Okay. So, but like she want to preserve her fertility as well, and there is nothing like that. She need actually aggressive management, so we can manage her conservatively. But you remember this, that if early, if cesarean scar ectopic is early and 𝗏𝗔 is not given or given and it is less than 5,000, then we will say this is a very small series correct topic and we can manage her conservatively via methotrexate. But the better option will be that if we combine local and systemic metho, combination is more better. Rather, more better will be the combination of medical and surgical management. So this table is going to save your life for other type of questions. Okay. So yes. So let me know if you want break. No question. Here we are. They said less than 8 weeks, only light bleeding, and children's correct topic, type 2 exogenous, and she's stable and she want to preserve her fertility, but is the most appropriate. Either we can pick option C or we can pick option D. So systemic metho is more ideal here as per this. Early, less than actually 8. Here exactly she's at 7 weeks and 𝗏𝗔 they have not mentioned, means it's not important and it is very small and asymptomatic phase, no significant pain, so we can give her systemic metho. Okay. Okay, so you people want break? Okay, I will give you break for I need coffee. No coffee. I need tea. Okay. And then after this we will complete. Okay. Now time is 10:47. Okay. Exactly after 15 minutes we are going to meet. We have covered many things. Now I will just read the question and you will understand. Trust me. Coming up questions will be, repeat questions. Because the recent exam was very important, many students have, failed it. They requested me and earlier they prepared individually or some, other study partners. They want to clear their doubts. So that's why it was very slow for this paper. But now we will actually read quickly and there will be no need to reading the slides again in details. Okay. So after 15 minutes, we will start. Okay. So now we are doing random questions right from 2016 till 2025, but they will be only on miscarriage concept. Okay. So in March, this question has come. We know this 21 SAC, so it's mean pregnancy of uncertain viability. We will repeat TBS after 7 days. You already know. And if SAC size is 25 or more, then we will discuss with her that she is having diagnosis of miscarriage and treatment option of miscarriage. Okay. So this next question, 29-year-old patient presents to her general practitioner with light vaginal spotting at 5 weeks, no pain, shoulder tip, no abdominal pain, shoulder tip pain, dizziness as syncope, and she has no history of ectopic PID and tubal surgery. And she is hemodynamically stable. What is the most appropriate management? So remember, in Irish, when gestational age is less than 6 weeks and patient is low risk for ectopic pregnancy, you don't have to do anything. You just have to advise her, go back home and come after 2 weeks or repeat. Do not come after 2 weeks, rather repeat at 2 weeks her just pregnancy test or UPT. Okay, that's it. No, why be? Why be? Okay. In miscarriage guideline 2025, they have specifically mentioned if patient is coming before 6 weeks and she is low risk, she is not having any risk of ectopic pregnancy. Right now, for you have not done any actually test as well. Do not need to do her TVS at all. Just reassure and send her, go back and come if any red flag, that's it. And repeat her UPT at 2 weeks. And if it is positive, again come back. And if it is negative, then just stay there. Okay? Remember this. This is very important. How you can forget it? In our theory, last session, we discussed this question there and with we were doing that Irish guideline. And I know those questions know this difference. But if you don't know, then remember it now. 31-year-old patient with a confirmed miscarriage choose outpatient medical management. She received mifepristone followed by 36-hour 800 microgram misoprostol, buccal route, and after 48 hours taking misoprostol, she has not developed any vaginal bleeding, but she remains clinically well. What is the most appropriate next step? Okay, so what you will do? She has opted outpatient medical management. We are not treating her on abortion care guideline. Now we are treating that she's having a miscarriage, and for her miscarriage, she opted medical management on OPD base. That's it. In cases when patient is having gestational age 9 weeks or more, her home is away, we can admit for inpatient as well. Okay. So what we are supposed to say that how much time she should wait after taking misoprostol. 48 hours has been passed. So advise her to contact the early pregnancy unit for assessment and consideration of second misoprostol dose, because ideally within this 48 hours she should start bleed, but she has not, so she will start taking the next dose. Do not mix it with abortion cares or termination cares on social grounds. That is different. Even NTD protocol is different in that case, trust me. Okay, so give me thumbs up if this thing is clear. If not clear, then stay and visit this guide. Okay, this is your guideline, and this guideline says first trimester miscarriage is how you will handle it. You can handle like conservative, you will do nothing, or you will do medical termination, or you will do surgical termination. And it depends on patient preferences and clinical stability. If she is not clinically stable, then obviously you will admit for EVA. Under GA, you will do her surgical evacuation. If she is stable, then you can go for MVA and medical drop, okay? And even expectant management. And if she is on expectant management, she will wait for 2 weeks, and in these 2 weeks, she will pass tissue, and once her confirmation of miscarriage is complete, we will do her ultrasound at 2 weeks. If ultrasound has been refused, then we will do her UPT at 3 weeks. So in expectant care, first we will do, I told you people keep writing the follow-ups. So write in your notebook. If patient has missed miscarriage, she opt expectant management. In follow-up, first thing is ultrasound at 2 weeks, and second thing is UPT at 3 weeks. However, in medical management, if patient is opted for medical management as inpatient care, then actually no need of follow-up at all. However, outpatient follow-up is recommended at 3 weeks after completing the medical management by either high sensitivity UPT or ultrasound. So ultrasound or UPT you can do any, but at 3 weeks. And on OPD base, not in inpatient care. If inpatient, then no need of doing any test. Neither if you have done STOP, no follow-up needed. So follow-up only needed if patient has opted OPD-based medical management or expectant management. Hopefully this thing will be clear. Okay? Okay. Give me thumbs up again. Okay. So remember, in early pregnancy termination, heavy bleeding, we will say patient is soaking 4 pads per hour or severe pain. She needs urgent assessment. And if she is less than 6 weeks, bleeding only, no pain, no ectopic, repeat urine pregnancy test in 2 weeks. This is recent exam question as well. Okay. And if CRL is this, and we already know about this incomplete miscarriage, we will say if she is bleeding and her endometrium thickness is 15 or more, and complete miscarriage, we will say if her endometrial thickness is 15 less. Okay. And if endometrial thickness is 30 mm, then better to do surgical top. Okay. And yes, they said stable patient we can manage conservative or medical. In medical, we will give mifepristone and misoprostol in complete miscarriage. However, if miscarriage is incomplete, do not give mifepristone. The way you you actually used to do in your MRCOG 2 exam. Okay. In incomplete miscarriage, no role of mifeprostone. And in surgical miscarriages, and again, I am telling you, this is not interim guideline or the guideline which is dealing the social abortions. That is entirely different concept and with different age, gestational age and entity recommendations and different follow-up. Do not mix it. This is that patient who's by nature she is having missed miscarriage or any miscarriage. Okay, and no, we are going to treat her either doing nothing or either as medical case management or as surgical. However, after 9 weeks, MBA and EBA is better, or when SAC is 30 mmR more. Okay, this is very important. And okay. In medical outpatient, we do 3 weeks ultrasound or UPT. And in conservative, we do at 2 weeks ultrasound. And if refused, then at 3 weeks UPT. Remember this. The entity is required. And in abortion care is required basically, we can discuss with her say shared decision making at 7 to 9 and after 9 recommended on abortion care protocol. However, if she is having natural missed miscarriage, then no need if she is less than 10 weeks, if this is expectant in medical management. However, if surgical management or surgically treated ectopic or molar evacuation, then you have to give NTD 250 international units before 12 weeks. And after 12 weeks, we will follow the NTD Irish guideline, and this is different. They give 25 international units. Okay. So, yes. Then complications and future pregnancies, and then I told you we will watch a movie together. You people are ready to watch movie? Our movie we can see in the end. What do you say? Movie? Or no movie? So movie time. So that was it. I think we will watch later. Let me to complete few important things. Okay. So remember, we were here. Yes. So she is less than 6 weeks, stable, no ectopic risk. So we will measure her UPT at 2 weeks. Option C. Okay. We have just covered this. Then we were doing 31-year-old patient and her process has not started in 48 hours. So she will take second dose. That's it. And next 32-year-old patient undergoes suction evacuation for confirmed complete mole. She is asymptomatic. Post procedure, she asked about the follow-up. So complete mole follow-up, everyone should know that see this one. Okay. So if patient is having complete mole, and we have done suction evacuation, after this we will monitor her serum beta HCG weekly. Okay, on the same HCG platform until normalization for 3 weeks. Normalization less than 8 weeks, monitor for 6 months post evacuation. And if beta HCG normal on serum weekly follow-up after 8 weeks, then we will monitor for 6 months post normalization. Okay, remember this. Complete mole, we will do weekly serum beta HCG. And if it is normal in 8 weeks, we will do monthly in urine for 6 months, and we will end after 6 months, and start date will be the day of evacuation. And if it is going to normal after 8 weeks, then we will start actually monthly in urine, and our start date will be that time when it will be normal. And the endpoint will be after the 6 months. And during this 6 month time, she will use barrier methods. She can use OCPs, POPs, DUMPA, any, but for sure she will not use intrauterine device. Okay. Okay, clear? And during follow-up, we will keep an eye. If any red flag and indication of chemotherapy, then we will check her score. And if on scoring, if her score is 6, we will give her single agent chemo. If her score is 7, we will give her multi-agent chemo. Okay. And for partial mole after section evacuation, you will measure her serum beta-hCG weekly. Once normal, the second we will do after 4 weeks. These two normal, that's it. Okay. And this thing you have to do for scoring. Scoring is very, very important. 0, 1 to 4 score. And there are 8 parameters. Each parameter is independent. Like if site is lung, her score is 0. But if inside lung mass is 5 centimeter, score will be provided 2 because they are independent markers. Okay. And in molar guideline, we have done a lot about how to calculate it, and very mnemonics we have already covered. Okay. So here we are. How we will follow up complete mole? Beta-hCG is likely to normalize within 8 weeks. 50% normalized within 8 weeks. Okay. Next, 29-year-old patient, light general bleeding at 8 weeks. TVS demonstrates an embryo with CRL8. No FCA is seen despite careful observations for more than 30 seconds, which is basically a standard time. So they have done TVS, and on TVS, we know that if it is 7, this is missed miscarriage. So here it is 8. However, if TS, then it was pregnancy of uncertain viability. Okay, as it is TVS, so we are very sure this is confirmed miscarriage. So we will say that she is having option C. This is confirmed miscarriage. But if it would be TS, then at 8 we will say better to repeat. Please feel the difference. Okay, so it's C. Diagnosed miscarriage. Okay, next, at 9 weeks, she is hemodynamically stable and wishes to avoid surgery. What is the most appropriate management? As this is a confirmed miscarriage at 9 weeks, the better is to do medical top. Okay, but better to do surgical top, but if refuse, then we can do medical top as well. So what we will do? We will give her 𝗪𝗶𝗪 followed by the misoprostol. I will show the doses as well. Remember the doses as well. They can ask the dose too, like 200 milligram misoprostol and 800 microgram misoprostol buccal root. Okay. Now medical management for past miscarriage, and 48 hours later she reports increasing cramping pain and moderate vaginal bleeding. So what you will do? This is very important. Basically, we have given her actually medical drugs, and now the drugs are showing their action, which are very predictable, isn't it? What we want that after medical termination she should bleed, and she's bleeding, she's having pain. This is which we actually want. So this is expected response to medical treatment. Okay, everyone is right. This is B. But here, if I will say that she's bleeding like hell, her pulse is rising, then no, it's not expected. We will convert it into a surgical top and she needs resuscitation. So any red flag, then this is not expected. Now, at 11 weeks, we are managing her inpatient medical, and she receives mifepristone. After this 800 microgram miso for 4 hours later, she has not developed with any bleeding and remains hemodynamically stable. So we are managing her as inpatient. So if we are managing her inpatient, we will wait for 4 hours only for second dose. And if we are managing her as outpatient, then we can wait for like 48 hours. Okay, as we done already. So what will be your option? She needs another dose, and it should be less than it should be half than 800. Like now we will give her 400 micrograms buccal and repeat after every 3 to 4 hours if required. Okay. Okay. Why D? Why Sophia D? What is D? Further 800? No. I will show the doses as well. I know those we have not remembered the doses, but no worries, we will revise them. Now in 2019 September, 38-year-old patient woman has a confirmed missed miscarriage at 11 weeks. She is hemodynamically stable and has no sign of infection. She lives 90 minutes away from hospital, no private transport. Now what they are saying, more than 9 weeks inpatient medical management indication, and she is living away more than 60 minutes, another indication. So how we will start her medical talk, as inpatient or outpatient? Obviously as inpatient, not as outpatient. So option B, inpatient. The reference is medical first trimester miscarriage, Irish guideline 2000-2025. Now, another question, 35-year-old patient presents with heavy bleeding due to an incomplete miscarriage, remains hemodynamic, unstable despite initial fluid resuscitation. What is the most appropriate management? Repeat ultrasound, expectant management, medical, emergency surgical. Obviously, she needs emergency surgical because she is hemodynamically unstable. So this is very, sensible option. Next, 2026 March, septic retained products of conception. What is the next step? So remember, but they are saying retained products of conception. If septic miscarriage because of retained products of conception, we have to remove them, and we have to remove them surgically. Even they said tomorrow or tonight or in morning. So do not wait. Do it tonight. Okay. If this is septic miscarriage, do it right and there after antibiotics cover. You will give first antibiotics and then immediately after this you will prepare for surgical evacuation. It's because she is having sepsis. And the next step will be the death if you will not remove. So option C, following antibiotics, we will remove these infected products of conception. A woman has undergoing successful medical management of first trimester miscarriage. She is now asymptomatic and vaginal bleeding has almost completely resolved. What is the next step? So what we should do? So according to the local protocol, she will do her urinary frequency test after 3 weeks, either by ultrasound or by TVS, either by ultrasound or by UPT. In OPD medical management, we used to follow the patient. However, in inpatient, we are sure that she actually expelled products of conception in front of our eye, and we can confirm that these are not non-molar tissue and complete evacuation has been done, then no need of follow-up. So here we will follow up. Routine follow-up is unnecessary after uncompleted miscarriage, confirmed evacuation according to the local protocol. Okay. Whatever is the local protocol, they have not mentioned inpatient or outpatient anything. So the only eliminated wise key will be option C. Is not it? But you know the ideal key as well. I told you. Inpatient, no need a follow-up. Outpatient, you can follow after 3 weeks, right? And neither follow-up needed in surgical miscarriage. And this is different from, Green-top, NICE, RCOG protocol. They follow up every patient after 3 weeks, whether medical, expectant, or surgical, but not in Irish. Okay, next, RH negative, first trimester miscarriage requiring surgical evacuation. Whenever surgical evacuation, you have to give NTD. Before 12 weeks, you have to give 215 conventional units. Okay. So B. What is B? NTD immunoglobulin she need. And units you should know, 250. Now it's 625. Irish guidelines say 625, but it does not cover the first trimester miscarriages. It covers the antenatal period. So after 12 weeks, the dose will be different. I'm telling about the first trimester dose. This is 250. So 10 plus 5, stable, no infection. She wishes to choose medical management. Ultrasound demonstrates a large sac. What is the most appropriate management? Obviously, larger sacs are better to treat as inpatient because they bleed more. Another hint. So you should know the inpatient medical management indication. Living away from hospital more than 9 weeks, or having larger sac, or having any bleeding tendency, or risk factors. Never outpatient medical management in that case. So this is 2022 question. 36-year-old patient had a medical termination at 8 weeks. No minimal bleeding, lower pain, temperature 37.9, ultrasounds thickness is 35, irregular tissue. So let me know, I told you people, endometrial thickness 15 or more than 15 means incomplete miscarriage. And she is having incomplete miscarriage, isn't it? With irregular tissue. So, and look at her temperature, it's more, ideally it's 37.4 and she's having 37.9. Right now she is not septic, but she can catch it soon if we will not entertain it. And she's actually here, what we should do. Okay, they are not asking the appropriate management. They are asking about the next step. Next step is antibiotic. Okay, which she need admission and she need antibiotic. And after this, we will discuss with, removal. And obviously, the better will be the surgical removal. Not tonight, because this is not sepsis. If it will be sepsis, then obviously tonight or now, there and then. So in my opinion, option D is better. Okay. Ideally, after antibiotics, you will remove. And EPEC have a 24/7 consultant cover. It's not like something tonight, tomorrow, nothing like that. So make sure if sepsis, then urgent create some urgency. But they are asking next. So next will be antibiotic in any mean, whether septic, whether infective. Next is patient is having mild bleeding, tender uterus. Again, 35 means incomplete miscarriage and afebrile. Now she is afebrile and she is just having incomplete miscarriage. So what is the best management? They are not asking initial management or next. So what we should do? Actually, she can opt both. She can again opt medical termination and she can opt surgical management as well. But the most effective and the best is surgical for incomplete miscarriage, one-stop treatment. So, okay. So I think A is better. No, B is better. Because she is afebrile. Okay, so no antibiotics. Agree? So we have to admit her now. Admission word with now, right? It's not like that we have to admit for right now, there and then immediate urgent evacuation. Okay, and for surgical miscarriage, if patient is not afebrile, patient is not febrile, we give only doxycycline oral for 7 days or for 3 days. So it's not like IV antibiotics. A 33-year-old patient, 40-year-old husband wishes to delay conception and she is 40. You counsel her that delaying pregnancy will affect her reproductive outcome. What is the most likely consequence is delaying the conception at the age of 40. So at the age of 40, there will be the more miscarriages. At 40, more than 50% miscarriages, and at 45, more than 90% miscarriages. You will see it in recurrent miscarriages guideline, this question and reference. 32-year-old patient, first trimester miscarriages, she and her partner are otherwise well and has regular cycle, pelvic scan is normal, everything is okay. So we have covered this. It was repeated recently as well and in 2018 as well. The most important treatable appropriate is always APLS, until unless something differently or a special buzzword. 24-year-old patient found to have 2 vaginas, 2 cervices, and didelphys uterus. And so didelphys uterus patients are in increased risk of preterm labor or increased risk of second trimester miscarriages. Okay. So option A, increased risk of ectopic, no. Increase of second trimester, yes. Increased rupture, no. Rupture is with unicornate uterus. Increased risk of primary infertility, no. And neither ovarian insufficiency. So didelphys, remember, every uterine anomaly is associated with more risk of miscarriages. Didelphys actually is also at risk of miscarriages, but preterm labor and specifically second trimester miscarriages are more as compared to first. Septate and bicarbonate are more associated with first trimester miscarriages. Didelphys is more associated with preterm labor and second trimester. Please remember this difference, because this single concept saves you multiple marks with later in your questions in OSCE scenarios. 25-year-old patient has undergone termination of pregnancy at 15 weeks because of 𝗫𝗫, and she has had 2 previous intrauterine deaths at 18 and 20 weeks. She is otherwise well with a normal BMI and no personal history of thrombosis. What is most likely underlying cause? So look at her age. And she is having like 1 in 𝗪𝗂𝗃 at 15, and after this 2 second trimester miscarriages, normal BMI. Okay, so I think the most likely cause can be the cervical incompetency, can be the chromosomal problems. No chromosomal problems. Why no chromosomal problems? The key is APLS. Okay. Like fetal chromosomes are more common in first trimester, but all her miscarriages are more common in second. In second trimester, chromosomes are only 1%. In first, they are 50%. So 1% is very less likely. So A out. B, yes, it can be, because APLS can come in first trimester as well, in second as well, and even in third as well, with sudden IUFDs because of fetal bradycardias, of cardiac blocks, because of SLE associations or preeclampsias. Okay. So yes, AB can be the key. C, inherited, no, never ever. Basically, inherited is linked with second trimester losses, no doubt. But for only one is enough, not 2 or 3. 2 or 3 are more specifically with cervical insufficiency. Okay, link is there for sure for second trimester losses of inherited thrombophilia, but actually we do not investigate for this, neither we treat for this. Diabetes less likely, anomaly. Okay, she can have uterine anomaly as well. Okay, but they said 3 or more. So actually, it can be E, yes, and it can be B. What do you say? Where we stand? Where we stand? I am facing difficulty with E and B. So many says APLS, yes, APLS, because we just have seen that less than 35 to losses, we can go for APLS workup, TFTs workup, and obviously CBC and but uterine anomaly. For APLS, the history of thrombosis is not compulsory. Only what I will say, I want to say that they have particularly mentioned in APLS that if any IUFD after 10 weeks, it should be normal, no gross anomaly. But here you can see anomaly as well. So because of this, APLS is less likely. In 𝗪𝗂𝗃, I can understand, but remember APLS feature. APLS has 2 features, one lab and one clinical. Okay, in clinical 3 recurrent losses before 10 weeks and 1 after 10 weeks, provided that it should be morphologically normal, but it's not morphologically normal. The baby is having 𝗪𝗪𝗃. And third is preeclampsia. So APLS clinical features, no clinical feature is is there. And for APLS, there should be 1 clinical and 1 lab. What is, just remember loud with me. For APLS workup, we want to meet the criteria. Clinical and lab. Clinical, 3 miscarriages less than 10. Here, are we meeting this criteria? Definitely no. Second, 1 miscarriage after 10 weeks, but morphologically normal. Here in 𝗪𝗪𝗃. Third, clinical, preterm delivery before 34 weeks because of preeclampsia or placental insufficiency not mentioned. So clinical criteria out. So I am thinking that second trimester it is more classical with cervical incompetency. Cervical incompetencies are seen within uterine anomalies. What do you say? I'm not happy with APLS. Anyway, I'm just skipping these questions. We will come and we will see it later. Okay. But this question has given many actually things in our mind. Like we can see that APLS diagnosis is what is APLS diagnosis, and like uterine anomaly specifically can come second trimester losses with cervical incompetency as well. Okay. You have just seen didelphys. Didelphys can come like this. This is a uterine anomaly. Anyway, 30-year-old patient, I will pick uterine anomaly. My key is uterine anomaly, not APLS here. 30-year-old patient, however, if three first trimester miscarriages, then definitely APLS, but they are not first three because one clinical criteria meeting. But here, not one clinical criteria, not a single criteria clinical criteria is meeting of APLS. 30-year-old patient is 6 hours post 𝗪𝗶𝗃 miscarriage. Okay. Okay. A 30-year-old patient is now 6 years post 𝗪𝗶𝗃 for a miscarriage. She is comfortable and mobilizing. Temperature is 37, IMEO score 1, and there is minimal vaginal bleeding. So, what is the best appropriate management? So, what is IMEO score? 50%. Okay. So, remember, IMUs are very important in early pregnancy and after postpartum in any sepsis scenario. Okay, so one yellow means like respiratory rate in this zone and temperature in this zone and heart rate in this zone and BP in this zone. So if any yellow, it's mean we will repeat full set of observations after 30 minutes and before 60 minutes. And this patient we can give oral antibiotics as well. And with two yellow or with one pink means she can have one pink from this or can have two yellow from this. Okay. So we will call the senior for review and repeat a full set of observations after 30 minutes. Okay. But here we have to add, call to senior for review. And with more than two yellow or means actually two or more than two pinks, call observation and request immediate review. Here they have added immediate review and repeat full set of observations within 15 minutes or even continuously. So two yellow, also do it like that way. One yellow, 30, 60. Two yellow, 30. Okay. And more than two yellow means 3. 1, 2, 3 yellow. 3 yellow means 15 or continuously. Okay. And yes, if sepsis criteria we take 3 and give 3, you already know this. You can read it, I mean, because we will do it in infection later. But you will see a lot of questions from yellow. 1 yellow, what you will do? 2 yellow, what you will do? 3 yellow, what you will do? Okay, so here we were. Yes. अब क्या चल रही है? Okay, I was just checking this question. So, one news course, like we have to repeat full set of observations. Actually, what I will say after 30 minutes and before 60. Okay, so this is our ideal key. And they said call the registrar. No, we call after actually at 2, right? And immediately at 3. So we will do elimination here. When there is no ideal, start elimination. So in 30 minutes, not good, because they particularly said right. Anyway, okay, maybe now I can write this. Yes, I think so. So this is not can't write. Now I can write it. It's not good. It's not good. Oral we need at 1. It's not good, and neither any actually like 37.4 is point 0 is less than 37.4. It's okay, fine. Discharge is not okay. Repeat is not okay. Okay. So what we'll do? She is comfortable mobilizing. So neither scan is indicated. So only option A is eliminated key. Because ideally we should do her observations after 30 and before 60. Okay. So probably this is, just a recall error. And even then, if it's a recall error, only the least wrong option will be the option, if you will be agree with me. She is comfortable, she is mobilizing, she is afebrile, she is good. Her IMEO score is 1 on only minimal vaginal bleeding. Without actually observation, it's not wise to discharge home immediately. She need 1 set of observation. Okay, that's why I'm just picking option A, because all are wrong and A is less wrong. Okay, and this is ideal. Agree or not? Should we move on next question or not? So I agree option A is not okay, but what you will choose then? You will choose another more wrong key. 26 at 9, she has bleeding heavily. Look at her vitals and products of conception are visible. Actually, incomplete miscarriage and going into shock. So what we will do, we will resuscitate her and will transfer immediately to the theater. Because this is incomplete miscarriage, we will do surgical evacuation. And 2019, this asked 28-year-old patient with uterine didelphys and transverse cervical septum. So losses at 22 weeks. See, the uterine anomalies are cervical incompetencies and notorious with second trimester. Okay. Her cervix was found to be shortened and dilated with no contractions. He wishes to conceive again. What is the most appropriate management for a future pregnancy? So what we can do? Actually, look at the size of septum. She is having transverse cervical septum. So can you proceed vaginally? No, you have to do trans-abdominal cerclage. She needs cerclage, but what will be the route? Because they said vaginal cerclage and trans-abdominal cerclage. See? And there is a septum here. So because of this septum, we can't opt A option. Ideally, it should be A if we can, because trans-abdominal we apply when patient is having failed vaginal cerclage, and failure means her pregnancies are ending, before 26, 28 weeks each time. It's mean this is a failure. If going beyond this timeline, this means it's not failure. This is recent article definition of transvaginal failure. Okay. So we are not opting it because of failure. We are opting because of difficulty in insertion. At transverse septum, it is difficult to approach vaginally. That's why transabdominal. Okay. And no metroplasty. Metroplasty is not recommended in Irish and even in RCOG for 𝗙𝗪𝗪𝗂𝗪 uterus or even for bicarbonated. Only one we can do, which is septate uterus. Only in that we can do metroplasty or septum resection. Okay. So this patient is coming at 6 hours. Her temperature is slightly more. Normally 37.4. Basically, IMS score 4. And again, eliminated key will be this. We have just done this. I think this is a repeat question. You have that 8 weeks IPLS and 3 previous first trimester miscarriages. She is currently well with no thrombic history, and she is asking for appropriate management. So for APLS, what we will give heparin and aspirin. Aspirin before conception, heparin at the time of confirmation of pregnancy, right? So next question, 25-year-old patient presents with heavy bleeding 5 days after a medical termination of pregnancy. Okay, so like if her BP, her heart rate, her ultrasound, so she's unstable. So if it's unstable, so she need urgent, immediate surgical evacuation. Okay. 28-year-old patient, uterine 𝗪𝗪𝗪 and with transverse cervical septum, we already know transabdominal cyclage will be perfect. 36. A lot of repeat questions are coming up. It doesn't mean I am duplicating them. Okay, they are actually has been repeated multiple times. So in next session, I will try that repeat questions I will not add. So we can quickly complete the session. Okay, 36-year-old patient, her partner had 3 miscarriages, a previous baby with Down syndrome. So what we will do, what is the most appropriate? So we don't know about actually much, but her age is 36. And again, the same scenario we have done. And I told you that we can go for karyotype and we can go for APLS workup as well. But I think here is no APLS workup. Immunoassay, parental karyotype, thrombophilia screen, hysteroscopy, and fetal autopsy. Okay. So better is parental karyotyping. Fetal autopsy is not required. We want fetal karyotyping. Okay. That's why E is not good. So I think the same question has been repeated with very close option with APLS. But here no APLS, so we will opt karyotype of parents. 36-year-old patient. At 8 weeks, she now presents with minimal bleeding and pain, temperature 37.9 more, otherwise she is stable. Actually, she is having actually infected, what I will say, it can be infected and it can be septic. Because if 2 SI race features are positive, then it will be septic miscarriage. Here, temperature, if 38 comes in actually septic range. So I think it is not septic, but for sure it is infective with the incomplete miscarriage. Okay. And they're asking next. So next with this temperature will always be antibiotics. Okay. Got it? So we'll give her antibiotics, IV route, and that's good. So similarly, if you remember the patient who has been treated in primary medical setup for primary termination for social reasons, if she's having mild fever, we can give her oral antibiotics there. Do you remember that question? But here, her source is present, which is incomplete miscarriage. She is bleeding and temperature is there. So here definitely better is that like we give her IV broad spectrum antibiotics. 29-year-old patient had a miscarriage and received medical management 3 days ago and no pain, bleeding, no fever. Ultrasound shows empty uterus. What is the next step? So, okay, I will take time here and remember, friends. Here they said she has confirmed miscarriage, so it means it's a intrauterine pregnancy. Okay, and she has received medical management and she developed moderate pain, bleeding, but now she's stable. And ultrasound is empty, so it's mean her process of miscarriage is now complete. So after complete miscarriage, what she will do? Opt reassure and discharge. Yes, she can, but it can be follow-up as well in OPD. If we know she has been treated on OPD base, and it should be after 3 weeks, either by ultrasound or by OPD. But admit no, discharge no, reassure and discharge okay. Perform repeat with SCG. So what about this? What about D? What is UPT? UPT is repeat with SCG, but after how much time? They have not mentioned. Neither they have mentioned serum or urine. So D is actually ambiguous. And our leading point is that best in next. So when they say best in next, so it's mean this is appropriate, in my opinion. When they say only next, then it's better to opt the next. When the best in next, appropriate, best, then better to pick the primary key. So primary key is definitely is that she don't need any intervention. She need reassurance. And right now we will discharge. And later, if it is medical OPD based treatment, we will discuss, follow up. Okay. So she has received medical management from GP. So it means it's an OPD. So it is, if it is next, so beta-HCG is better because it's mean UPT. Okay. And if they said appropriate, so appropriate key of complete miscarriage is reassurance, no intervention in terms of another attempt to, give the drugs, etc. So be mindful whatever they ask you in exam. Trust me, be mindful. You will, the key can be in their key. They are very particular. The key can be the repeat serum beta-HCG after 3 weeks. So do not opt the reassurance and discharge if they are not putting the word best here. Okay. 27-year-old patient presents with secondary menorrhea. She had dilatation and missed cycle 8 months ago. FSH is normal, pregnant test is negative. Why secondary menorrhea with FSH normal and after surgical intervention? This is classical presentation of Asherman. In Asherman, FSH will be normal and patient will not bleed because of the enzyme. 34-year-old patient with 2 previous first trimester miscarriage disease, now 10 weeks pregnant, lupus is positive on 2 occasions to 12 weeks apart, confirmed APLS. So if it is confirmed APLS, we will give aspirin and heparin. Okay. Now, 22-year question, 34-year-old patient post 𝗪𝗶𝘃, mild tachycardia, 1 yellow, and again it's coming up. Repeat vitals in 30 minutes with IV fluids. Okay, 𝗪𝗶𝗀𝗃 says. Let me think. I think this is okay, fine. Oral fluids and oral antibiotics we want in 1 yellow. Okay, why IV? No IV. We give in 2 yellow or in 3 yellow IV fluid. Okay, and ideally it should be after 30 minutes, not in 30 minutes. Okay, at or after will be more better. Rather after. This is ideal. Should we move? We will not give oral antibiotics for sure. If needed, we will give. Now 16 ultrasound shows CRLL 16 weeks, no FCA, she's independently stable. Okay. So remember, what is the ideal key? What should be the ideal key here? A patient is at 16 weeks, means second trimester loss, and it's a missed miscarriage. And after 14 weeks, Irish do not recommend surgical top because bones has been developed and it's difficult to, remove the bones surgically. So after 14, better to consider medical top, and for sure after 16, you have to go medical for medical top. Okay. So what is the next step? And she is stable. Ultrasound shows CRL. We don't actually, the question has certain serious issues because CRL word is not used after 14 weeks. It's used before 14 weeks. So it means they are saying that she's having HC corresponds with 16 weeks because HC is reliable after 14, okay? And yes, and she's stable. And okay. So this is confirmed miscarriage at 16. CRL, obviously it will be more than for sure 7. Follow-up out, follow-up medical expectant out. Okay. So I think we will go with elimination process. Follow-up 7 less likely, 14 less likely. Yes, we can discuss medical management induction. Yes, repeat ultrasound within not needed. Expectant management for 2 weeks, not for 3 weeks. So it's not okay. So option C is only eliminated key, right? Right? In partial mole after 15 we do medical combination. Yes, same like that. So here, give me thumbs up if you are comfortable with option C. It is your 2020 MRCPI recall. Hello. Okay. Because expectant is not ideal after 9 weeks. And here we are at 16 weeks. Expectant is better when miscarriage is incomplete, sac is irregular, OC is open, or patient is less than 9 weeks. 42-year-old patient primary had a missed miscarriage loss at 22 weeks, preceded by the lower pain. Histopathology shows placental necrosis. She attends for preeclampsia counseling. Placental necrosis means placental issues in invasion issues in placenta. Okay, what is the best marker of our next pregnancy? Okay, we will eliminate. So 22 weeks, 1 preterm labor. She is, candidate for ultrasound indicated circular because of this. And here necrosis means low preem. Okay, our key is preterm clinic because of this. 1 preterm serial cervical length every 2 weeks. Because 1 preterm is like for ultrasound indicated, we categorize the risk, intermediate or high risk. If patient is having preterm, this is high risk. We have to do serial cervical length measurement between 16 and 24 weeks. Okay, so it's okay, fine. An infection, obviously, because it is necrosis. So option A is perfect. So now check the option B. Routine, no, it's not a routine. Preterm clinic with single cervical. Why single? She needs serial because preterm is high risk for ultrasound indicated cervical, and for high risk we have to do serial and high dose progesterone. Throughout, if we have to give progesterone, we start it, before 24 till 34. That's it. Empirical, why empirical? So out, this is not a recurrent miscarriage, neither APLS. So only option A is it can make sense. Okay. Next, 32-year-old patient at 9 weeks with vaginal spotting. TVS shows a sac with mean sac diameter 22. At 22, it is less than 25, so we have to repeat. Okay. Next, 7 weeks with light bleeding and shows an embryo CRL 8 mm and no activity, and it's TVS. TVS and it's confirmed miscarriage. So option A. Okay. Next, 10 weeks bleeding, ultrasound confirms an embryonic pregnancy. She is stable and wishes to avoid surgery. What is the most appropriate management? So she is bleeding, and this is confirmed miscarriage. What is anembryonic pregnancy? Anembryonic pregnancies means sac is there, but there is no fetal pole. Okay, only empty sac. Means a sac size 25 or more without any fetal pole. This is anembryonic. This is blighted ovum. They are the older terminology, basically. So what we will do, we will actually discuss with her and because they said this is confirmed anembryonic, so it's mean this is confirmed miscarriage with the sac without fetal pole. And if she don't want surgery, basically at 9 weeks surgery is more best. But if she don't want, then medical is okay. She can opt any method. We need her consent. Autonomy is more important, okay? 35-year-old patient had 3 consecutive miscarriages and she has lost more than 10 weeks with fetal heart rate previously confirmed. So here, what you will give? Because two clinical features meet. 3 first trimester miscarriages and 1 after 10 weeks. 3 before 10, 1 after 10. So definitely we will confirm her, we will evaluate her for APLS. Okay. So test for APLS. Why without investigation we should give her 𝗪𝗶𝗃 heparin? Why? 30-year-old patient. Anyway, just imagine a patient who is having 3 recurrent pregnancy losses before 10, after 10, a normal morphological baby, and at the same time she has developed 1 preterm labor, 1 preterm delivery before 34 weeks because of raised blood pressure, and now she is pregnant and at 6 weeks. So what you will think? This is not your written exam question. This is your 𝗪𝗀 exam question. And this, like in pregnancy, we don't do actually APLS workup. But she is fulfilling the criteria of clinical features of APLS. So it's wise that we should send her antibodies, right? And we will consider to put her on allopurinol and heparin. Why? Because she is fulfilling the very strong clinical feature of APLS, which is preterm labor before 34 weeks. Okay. And if she is not fulfilling this very strong feature, and she is coming with recurrent 3 pregnancy losses before 10 weeks, then this is very weak feature because it can happen in chromosomal issues as well. So what we will do practically, we will again send her labs, and if her labs are positive for antibodies, we will repeat second after pregnancy, and meanwhile we can put her on 𝗪𝗶𝗃 and heparin. If her labs are negative for antibiotics, then we will not for sure give her any 𝗪𝗶𝗃 and heparin. This is for 𝗪𝗪𝗧, or your for clinical experience or your OPD practice. This is not written question, okay? Anyway, 30-year-old patient, 6 weeks pregnancy, and previous shows a sac with mean sac diameter 18. So 18 is less than 25, so for sure we have to repeat it after 7 days, okay? Next, 8 weeks bleeding, cramps, so os is open, and RPOCs are present on scan. So what we will do, as patient is having heavy bleeding, so we will not wait that she should bleed more and come in next time with shock. So we will do her surgical evacuation now. Okay. A 35-year-old patient attends for a routine clinic scan at 10 weeks. PVS shows CRL 12, more than 7, very late. So this is confirmed miscarriage, and and but she's not bleeding and she has no strong preference, but she want best. So best will be surgical evacuation at 10 weeks. Okay. Best will be expectant management. No. Basically, she can opt any. If I will say that she has no strong preference with any method. So, and in that, the best after 9 weeks will be the surgical evacuation. Okay. But if she has strong preference with no intervention, then expectant. Clear? So see this guideline. This is our, like Irish guideline. They said miscarriage options, discuss management options relevant to woman's preference and clinical indications. Conservative means expectant woman preference, clinically stable. There should be no instability, infection, molar, or medical conditions which can increase the risk of hemorrhage. Okay. And for medical, again, woman preference, clinically stability, and cytogenetic sampling as inpatient management if she is having recurrent miscarriages and we want to take fetal products of conception for cytogenetic analysis. Contraindications like not stable for this, surgical preference, previously unsuccessful conservative or medical management, or we need cytogenetic sampling. Like a patient who is having recurrent miscarriages and it's her third miscarriage, she comes to us and her OS is open. So definitely we will opt best management surgical because we can have fetal tissue as well for histopathology. Okay. And in this here they have not mentioned. No, they have mentioned management conservative or surgical. Okay, they have mentioned the surgical is better after 9 weeks or when larger sac means 30 mm. Okay, here they have mentioned. So before 9 weeks, medical expectant both okay, but after 9 weeks, the best is surgical. Where we were basically here. Okay, we were here. So agree with this. The best is surgical evacuation after 9 weeks, and she's at 8 weeks, and she has no strong preference with any method. Means her decision is not important. So what is best? We have to choose now. Now, 26-year-old patient at 16 weeks, no movements, and transabdominal ultrasound confirms demise. So we will actually hemodynamically stable. The best is always actually induction. Okay, induction is best. Expectant management is not best, although appropriate in certain situations. Because if we will manage expectantly, more chances will be, DIC and so many interventions. So if it's up to us, then medical is better. If patient want no intervention, then expectant is better in our view. 25-year-old patient at 7 weeks presents with spotting, no pain, TBS confirms intrauterine pregnancy with no fetal cardiac activity at 7 weeks. So what we should give? At 7 weeks, for sure, surgical out. Okay. So there is a confirmed viable intrauterine pregnancy. So this is the normal pregnancy. Why miscarriages? We can give progesterone because she's having bleeding spotting. Right? This is progesterone because progesterone we give threatened miscarriages and also in recurrent, unexplained. Okay, so option I think C. Why they are saying expectant? We will do expectant. Bed rest advice expectant recommendations. Is it that and is very reliable most contagious bed? So we will give progesterone. Progesterone is a sportive key, not a primary key. Primary key is still that do not do any intervention. Okay. So they are asking two things. If they're asking the best, this is advice expectant. Okay. If they're asking the next, then it will be the progesterone. Hopefully you will get it. No. If patient is having threatened miscarriage, what is our intervention and viable intrauterine pregnancy? What we should do? We should do nothing. Leave her on its own. Do not intervene. Intervention in terms of any surgery, like aggressive treatment. This is the primary key. You will agree with me, I know, but I have to convince you by giving another scenario. Remember, a patient who is coming in latent phase of labor with pain, 3 centimeter, irregular pain. So what you will do? Appropriate treatment, what will be? PCM or no intervention? Reassure, send her home. Yes. Now agree? So this latent phase is like the threatened miscarriage. He is bleeding. We can't stop bleeding by giving any, thing. We just wait and watch. This is our key. So expectant management is our primary key. However, we can add progesterone. It will relax the uterus, and in some cases, like we can see the benefits. Now agree? The primary key is no intervention or expectant, and sportive key is progesterone. Like latent phase patient coming with pain, primary key is no intervention, reassure, send her home, and secondary sportive key is that just give her PCM. Now give me thumbs up if this concept is clear. Let me know. Okay. So so I agree. Be mindful in your exam. If they are asking next, give progesterone. If they are asking appropriate, then better do not intervene. Okay. Basically, threatened miscarriage, the more ideal situation for progesterone will be that if previous history of same threatened miscarriage, and now again recurrence. So whole criteria is not developed. 34 age, first trimester miscarriage has positive APLS, has no planning next. So this is easy. We will give her aspirin and heparin. Now 3 miscarriages and normal scan 37 and 3. So APLS makes sense, and fetal or parental karyotyping makes sense. Okay. So they said the most appropriate is APLS, and because it has some treatment influence as well. Whether equally okay can be okay karyotype, but no therapeutic influence at all. 41 age, second trimester loss, histology shows placental necrosis. We know this, that She need preterm labor review in preterm clinic, and she need a serial cervical length assessment, and she need aspirin. Okay. So this is incomplete question, but detail we have already covered. 32-year-old patient, previous second trimester miscarriage. Now at 22 weeks, TVS ultrasound at 16 weeks, so cervical length 20 m. So this is less. One preterm and cervical length short. So we give her on priority. We will discuss it large, not progesterone only. She is candidate of history indicated. No, ultrasound indicated. Why history indicated? For history indicated, there should be three preterm labor or 3 second trimester losses. Okay. Here only one, previous second only one, and with short cervix. For history indicated, we don't need actually short cervix at all. See, for ultrasound indicated, we need cervical length? No. How many actually preterm labor we want? 3. So sorry, for history indicated, we don't need cervical length, only 3 second trimester classes are preterm labor. We will discuss her ultrasound indicated cerclage after combined screening test or NIPS normal. Okay. And for ultrasound, we will see that she is having preterm labor 1, less than 3 preterm labor. Okay. And with short cervix. So we will, after anomaly scan, we will apply ultrasound indicated cerclage. And for rescue, 16 till 27 plus 6. Anytime if patient comes with, cramps and exposed membranes, on clinical criteria, we will apply rescue cerclage there and then, provided there is no active bleeding, infection, and contraction. Okay. So here 10 weeks and look at her BP and pulse, and she is having heavy bleeding, passage of clots because she's still, passing clots. So it means an incomplete miscarriage. So we will do her ERPC tonight. We will not wait tomorrow. We will not review early pregnancy unit after 1 week. We will not just only give her antibiotics while she is in shock. Neither we will await for spontaneous completion. A woman at 5 weeks with heavy bleeding and cramps, ultrasound shows retained products of conception with endometrial thickness 20. 20 means incomplete because 15 mm onward means incomplete. Okay, she is stable. So what is the best? Best in incomplete with heavy bleeding is always surgical. So as she is not yet into shock, she's just bleeding heavily. That's it. So we can do MVA as well. Why not? But if she is having sepsis or she is having, contraindication of MVA, what are the contraindication of MVA? Remember. Screen is visible, I think. Let me know if anyone also facing the issue like this. So MVA, gestational age should be less than 10 weeks. Fibroid should be less than 12 weeks. Okay. CRL should be less than 25. And POCs should be less than 5 centimeter. Okay. And patient can actually bear the pain, and there should be no cervical stenosis. Only then we can do MVA. Okay, remember this. But if these criteria are not met, then go for under GA surgical evacuation in OT, which we used to say EVA, electronic vacuum aspiration. Okay. So 30-year-old patient, recurrent posthumous miscarriage and septate uterus. For septate uterus, Irish and GTG both says that MRCPI hysteroscopic guided is okay. Not very much favorite, but only this is the only one and only uterine anomaly which we can treat, and it results in live birth rate and less miscarriages. 26-year-old patient and 28-year-old partner have had recurrent miscarriages with the previous baby with Down syndrome. So what does it mean? Down syndrome is not a recurrent issue, okay? What is the, it can be recurrent issue, no doubt. 1% recurrence, okay? And if maternal issues, then it can be more than this, okay? What is the most appropriate investigation? Having recurrent, okay, one baby. So chromosomal appropriate or parental karyotyping, whole genome sequencing, non-invasive fetal DNA. Because of one Down syndrome, she need invasive test. Next, okay? And for invasive test, they have to do the fetal CVS RNA synthesis. And if it is not available, then we can do NIPCS as well, okay? So what will be your key? We can do fetal RNA, not DNA, so E is not okay. And she is not having only Down, she is having recurrent as well. So with recurrent and Down, together we have to pick a single key which can cover both. Let's do it with together. Okay, chromosomal microarray. Microarray of conception. Basically, I want this for Down. Trust me. Okay. Yes. Then they said parental karyotype. How many recurrent? 3 or 2? So definition is 2, basically, at this age. So it's minutes 2, okay. What is the, yes, A is okay because of Down. B, parental karyotype is okay because of recurrent. Okay, whole genomic not needed, non-invasive. Prenatal test not needed because we want diagnostic test, neither this. So it can be A, yes, and it can be B. Take its screenshot and you will agree with me why I am so concerned here. Okay, you will agree with me. So let me know if a patient who is having, Down syndrome, a risk on NIPS. So what we will do, we'll have an invasive test. And invasive test, what we send karyotype. And the best method to test karyotype is chromosomal microarray. Okay. They are associated with less culture failure, less contamination. And because of recurrent miscarriages, we have to do parental karyotype. Agree? See, if patient is having one Down previously, by default, we have to do fetal karyotype via this microarray method. There is a TOG on it as well. Cause okay, I got it. Actually, you are very right here. Because we don't have fetal products of conception, so that's why we can't do chromosomal microarray of products of conception. Yes, you're right. I wonder why I skipped it. It's not easy. Thank you very much. You are right. Okay, because as we don't have products of conception, so ultimately we can do what is available, and this is parental karyotype. Thank you very much. Yes, your brain is working, Aisha. Better than me. Okay, thank you very much. You solved the puzzle. This is the, okay. So you are facing postpartum time. 2 weeks postpartum. Great, brave lady. So it's a baby boy or a baby girl? Oh, baby boy, mashallah. So have a speedy and full recovery. So Aisha, you are right. Next question is 27-year-old patient, 6 weeks gestation, has a TBS showing sac with no fetal pole. She is asymptomatic. What is the next best step in her management? Basically, she's at 6 weeks. Okay, and no fetal pole, and we don't know the size as well. So by default, limited will be that we should rescan. But if they will give us the measurements, then we can say that what is this. Otherwise, we can't say anything. This is poor record. So after 3 days, 𝗪𝗶𝗃 heavy bleeding and thickness is 15. So because this is heavy, so we will do repeat evacuation, and either we can do via MVA or with EVA. Okay. But for sure, like EVA is better because she's hypotensive. No MVA. No MVA. So option A. Next, 29-year-old patient at 7 weeks presents with general bleeding for 12 hours. Look at her BP, pulse perfectly okay. TBS live intertime pregnancy. OS is open. This is inevitable, I guess. And this is SAC is cited in the lower uterine cavity. So how what we should do? We should do nothing because inevitable we leave her. But like we just say that wait and watch. But the way we say like 𝗙𝗵𝗃𝗀𝗪 coming at 23 weeks, what we can do? And she's 7 centimeters. We should do nothing. Leave her alone. She will expel herself. So I think it will be D. So why they're admitting as OS is open and okay, as OS is open with the sac that descends to the lower cavity is an inevitable miscarriage even through PCA, the pregnancy will not salvage and the tissue is discharged because she is stable and bleeding is not heavy, no immediate surgery is required. Decision is unsafe with an open nose and a live pregnancy. Yes, they are saying we will, in patient management, we will admit her and during admission we will do nothing and we will manage her expectant care. So option B, admit and observe. Observe holds the option of D in itself, means expectant management. B is more ideal. D is good, but B is more ideal. Okay. Better to actually, because if we are opting D, it can be that she can go home. But with expectant management, we are admitting her as well. This is more wise and mindful. Very close. And 30-year-old patient presents. You agree with this? Admission with expectant care is more better. Yes, actually, the key is no doubt it's it. But the B is more perfect. We will do expectant. Our expectant means observation while she will be admitted. Because she can bleed, like her bleeding can go in any way, na? She need our assistance. But right now, she do not need anything like fluids or anything. 30-year-old patient, 7 weeks amenorrhea, minimal spotting, mild pain, UPT positive, scan shows entire uterine sac with no fetal pole and no sac, mean sac, and no yolk sac, but sac is there intrauterine. It is 15 mm. So 15 mm means less than 25. We have to repeat in 7 days. This is pregnancy of uncertain viability. It can viable later when the threshold will meet. Okay, a couple attend the recurrent pregnancy loss clinic after 2 early pregnancy losses. She now has a positive pregnancy. Neither partner has any significant medical history and investigation for APS and structural anomaly were negative. So what is the best management? Okay, so this is unexplained. They have ruled out that no structural problem, no actually APLS issues. So what we can do, start low dose aspirin and progesterone because okay. So Aspirin to the horses. What else we can give? Because B is not okay. Folic acid is quite generic. Close monitoring serial ultrasound not needed. So option A is okay. And it is unexplained. That's why aspirin and progesterone makes sense. Okay. So we know this. A 25-year-old patient, 7 weeks, presents. What are you saying, Safia? A 25-year-old patient, 7 weeks gestation, presents with heavy bleeding. Hemoglobin is 8.2. Cervix is open and the tissue at the O's. Transfusion is not required right now, only at this hemoglobin. However, it will be if it will be 6 or less than 7, then definitely. Antibiotics not needed. Surgical evacuation not needed. I think expectant again. Why surgical? Heavy bleeding. Okay, heavy bleeding. So you missed heavy bleed. Okay. Next, we need sleep now. I'm just going to complete 2020, 24, and 5. 26 we have already covered. A 32-year-old patient has a history of 1 mid-trimester loss and 1 preterm birth and previous 𝗪𝗔 high-grade dysplasia. At 18 weeks in current pregnancy, TVS shows cervical length 1.5 with funneling. What is the most appropriate next step? So this is very good question for brainstorming. Okay, so see. 1 mid-trimester loss, like ultrasound indicated cerclage, okay? Previous 𝗪𝗔, ultrasound indicated indication of cerclage, okay? 18 weeks, again, good time for ultrasound. TVS shows cervical length, again, ultrasound indicated, okay? Funneling is nothing. However, if the same patient comes with, pain, tightening, and membranes are exposed, then we can go for rescue cerclage. So what we should do, we should go for cerclage. And how? She's at 18 weeks. At 18 weeks, transdental. Okay. So 2025 questions. A 28-year-old patient, 8 weeks, and ultrasound shows gestational sac 40. So 40 means miscarriage. Okay. If she is bleeding, no, even if she is bleeding, then it's miscarriage. Statin we use when there is viable intrauterine pregnancy. 29-year-old patient after medical termination at 7 weeks, irregular thickness, bleeding but light, but temperature is lower, tenderness is there. This is actually infective miscarriage. So otherwise she is stable. And next step is that she needs antibiotics, admission for antibiotics. Yes, next is this. And after this, they will do surgical evacuation. A couple with a history of recurrent miscarriages presents at 8 weeks with mild vaginal bleeding. A viable intrauterine pregnancy is confirmed on scan, and her APS screening is negative. So what is the most appropriate prescription? 8 weeks, mild bleeding, recurrent, and viable intrauterine pregnancy is there. So we will treat her as, that I will say that unexplained again, because APLS workup is negative. Okay. Now they are asking 29-year-old patient, 9 weeks, heavy bleeding and pain. So usually only in abortion care protocol, at 7 we discuss, at 9 we give anti-D. But on natural miscarriages pathway, before 10 we don't give anti-D if it is not surgical miscarriage. However, if bleeding is heavy and pain is there, this is exceptional, we can give anti-D. Okay. Anti-D is mandatory for all negative non-sensitized patients having surgical. Apart medical or expectant, this is not needed, but we can give, that if there is, pain and bleeding. Okay. And ectopic, if surgically managed, as per Irish, we give NTD, not in medically managed. Remember NTD rulings?
को आंसर क्या था इससे पहले एनटीडी वाले का इससे पहले सॉरी
Aspirin and vaginal progesterone, because she is bleeding and unexplained, that's why aspirin. And actually, it's not unexplained as well. We have not done her, TVS and so many investigations, but only eliminated key is this, because look at B, folic acid only. Look at C, only aspirin while she is bleeding. D, like only vaginal progesterone twice daily only. So, and at weeks we can't do anything. So we will give her benefit of doubt and giving aspirin. And they have sent her workup as that, the most important workup. It is negative, but means no APLS. So here we will give an idea that this is unexplained. So that's aspirin. And as she is bleeding, so that's why progesterone. Okay? Okay?
Yes, ma'am. Okay.
You can argue with me, why not only vaginal progesterone? Because whole workup has not been done. And if it is not right now unexplained, so we can give aspirin as well. You are right here. Again, I will say you, if you are thinking in that way, you are logical. But in my opinion, they have added one APLS negative. So but I have actually seen it's in exam with this statement, they will add everything, that this test is negative, no structural anomaly, no parental issues, no APS screening. Then you will guess, then it is unexplained. Then it will be more wise to add aspirin. Okay? This is not a very good
theory, ma'am. If there's a vaginal bleeding, we can give aspirin or no?
Yeah, we can give. We can give. But if thrombocytopenia and DIC, so then better not to give. In those situations, we withhold. Okay, next entity we have discussed, entity. So termination, in termination, before 7, no entity, at 7 to 9, offer entity, and women can decline as well, share decision making, but at 9, we have to give. And it is termination or abortion interim guideline. But 2022 guideline says that any surgical, you have to give entity within 72 hours, 250, medical, no need, expectant, no need. However, if there are more bleeding and pain with the medical and expectant, you can consider to give entity. Okay? So a 28-year-old patient has a missed miscarriage at 8 weeks. Ultrasound shows gestational sac 32. She is clinically stable and prefers definitive is surgical. Okay? EB or MBA. 7 weeks, mild bleeding. Ultrasound shows sac up to 24. She is bleeding. Obviously, we will can consider for progesterone, but threshold has not met. So definitely 1 week scan is important. So we have the more primary keys, we have to repeat 7-day scan. And we can consider progesterone if viable pregnancy, threatened viable pregnancy this time with previous same history. 30-year-old patient with miscarriage presents with fever, heart rate 120, blood pressure. She is in shock. So she needs fluid resuscitation, option B. Next, she's soaking 3 pads per hour and heavily actually bleeding. Pulse is more, ultrasound having retained products means more than 15 mm, which is 18. So it's an incomplete miscarriage and heavy. So what you will do? We will do oral? No. Urgent ERBC, yes, because now currently she is bleeding heavily. So, March 2025, 27-year-old patient, 8 days after medical management of miscarriage, presents with low-grade fever for 37. She is infective, pelvic discomfort, offensive discharge. Okay, she's stable and ultrasound shows retained products measuring 12 mm. So it's not, so it's a complete miscarriage. So remember, septic miscarriage can be without RPOCs as well. So if there are no RPOCs, as they said, 12 mm thickness, this is normal thickness. Because for incomplete, we have cutoff of 15 mm, okay? So we need only she need only antibiotics. Okay? Not oral, but let start work of elimination here. So reassurance and review, no. Oral antibiotics you need, but not oral. And immediate ERPC not needed because it's complete miscarriage. IV fluid and ICU referral. Why? She's having infection, not sepsis. Outpatient scan in 2 weeks, neither this. So only eliminated key is option B. The better is IV, but we can give oral as well. Okay. So she is having discomfort, she's having fever, but her fever is not in septic range. It's only infection. And it's not actually standard recommendation to give in this situation always almost IV antibiotics. We can give oral as well. Trust me. And for me, just actually do your own homework. I have done. 33-year-old patient. Yes, 33-year-old patient, 12 days after conservative management of miscarriage, presents with fever. Now fever, look at the fever. Offensive discharge, moderate. Here she need IV antibiotics, okay? And look at the tissues, 20 mm. Okay, here she needs. Okay, this is septic miscarriage here. 33-year-old patient, 12 days after conservative management of miscarriage, presents fever. And again, we have done this. Now, 36-year-old patient, ERPC for incomplete miscarriage during the procedure. There is sudden loss of, now it's perforation. Okay. So what is the next step? Continue, no. Observe in recovery and discharge, no. Arrange immediate laparotomy, no. Perform diagnostic laparoscopy, yes. Administer antibiotics only, no. We will give antibiotics, definitely, but later we have to do laparoscopy as well. So primary key is laparoscopy. And they're asking the best step. When they said next best, it's mean appropriate. Okay, agree? Now, 34-year patient, one previous miscarriage at 8 weeks. Now, analysis confirmed. She requests analysis. So how we will do with this? We perform after 1, no, after 2 we perform. Only perform after 3rd miscarriage. Only perform alongside parental karyotype. It can be performed after written consent. Do not perform at this stage after parental karyotype only. 1 previous miscarriage. Okay, and she requests messes up. Acha, now this will be the second one. Okay. Now this will be the second one. Basically, she is also having second miscarriage. And for this second miscarriage, she is requesting that send her. So we can send. Because before 34, 2 are enough for karyotyping. Correct answer C. No. What is our key? Perform only. So C is okay, fine. Obviously, we can perform, or we will actually ask for consent. For karyotype, we have to take written consent. You know, this is clinical governance question from ethics and consent. In which conditions you have to take a verbal consent and written consent. So anything is concerned with, baby postpartum or fetal products of conception, you must have to take written consent. So I think this question is from that module. Okay. Do you know if patient is having undergoing emergency cesarean section, we can take verbal consent as well. Okay. But here written, I always become surprised. Anyway, a couple attends the recurrent miscarriage clinic and she's at 10 weeks pregnant with a viable intrauterine pregnancy. What is the best management? 10 weeks and viable. Okay. So this is incomplete question basically. Only incomplete question. No. But like it's mean that they have listed a lot of information and every investigation will be normal. Then we will take it as unexplained and we will give aspirin. This is a repeat question. 31-year-old patient is now pregnant and ask about to take. What advice you will give? Okay, same question. Okay, now we are facing a lot of repeat questions. Heavy bleeding, that's it. We have covered 35 mm. IMEO score 2. When IMEO score 2, repeat observations in 30 minutes. This is now perfect, okay? Now I think this is the same question, but now it's coming with proper option. Okay, IMEO score 2, comfortable tolerating oral intake. So how we will monitor her? We will call actually consultant, but not urgent. Consultant or any senior, it can be senior midwife as well. And we will observe her in 30 minutes. And if 3 yellow, then urgent call. And continuous are in 15 minutes observations. 2 previous miscarriage presents with a miscarriage 8 weeks and request, okay, written consent. We know this. But this in 37. Okay. At 37 with previous 2, and now miscarriage, it's 3rd. Even then it should be option C. It's not A here. Okay. It's 3rd miscarriage going on. This is option C. Trick is that you have to check 2 here and this is not complete. In my opinion, this is also going to be happening as a miscarriage. It will be something like that, inevitable miscarriage, like O's open. Okay. So thank you very much. This was the last question and we have already covered 2026. But still in my 15 slides I have not covered. Having very straightforward questions on hyperemesis gravidarum. Should we do them? Actually, I think the session was very long today because early pregnancy is very important. We have, covered everything of early pregnancy from very basics. That's why we took that much time. So let me know if you're interested. I can cover hyperemesis. We covered molar. We can do if you're tired. It's only 9. Okay, we can cover. Okay. Why not? Okay, just give me 5 minutes. Only 15 slides. Trust me, not more than 15. Yes. So for hyperemesis gravidarum, on Irish perspective, you need to do these things. Peak age 9 to 11 weeks, and it improves usually between 16 and 20 weeks. So if a patient is having nausea, vomiting excessively after 20 weeks, then it's less likely that it is because of pregnancy. You have to rule out the other differentials. And if the first onset is after 11 weeks or 10 weeks after, then this is less likely that it will be relevant to pregnancy. It will be other cause like GIT or stones or UTI or other thing. Okay, so like the most important timeline for peak age is 9-11, and it should resolve by 16 and 20 weeks. And if anything is odd and not like behaving physiologically, nausea and vomiting, then you have to investigate earlier the differentials and you have to exclude them. Okay, with these concepts you can solve a lot of questions. And every patient who is having nausea and vomiting in pregnancy, you have to quantify its actually PUC score, pregnancy unique quantification estimation. So on this, we give how many times she is, having number of vomitings and, retching. On this quantification, I'm not going into detail, neither it's required. We will score her. If it is mild, which is 6 or less, it's actually, we'll say this is mild. With moderate, it will be like 7 till 12. And severe means 13 and more. Okay, mild, moderate, and severe. Okay. A moderate score may require admission for dehydration, electrolyte disturbances, rapid weight loss, and any other things. But if score is severe, then we have to admit her as inpatient. We should give her, take her history, what is gestational age, and her tolerance, color of her urine, her pregnancy weight, her weight loss, and everything. We have to examine her vitals, her physical signs, for dehydration specifically. And then we have to rule out these, red flags. Like they are immediate. If she's unstable, syncope, sepsis, VT, chest pain, sepsis, okay? And biochemical triggers are like she's having hypoglycemia or hyper, are having abnormal RFTs, 𝗵𝗂𝗪𝗔𝗍, abnormal amylase, lipase. And if it is occurring after 10 weeks, it is less likely that it is physiological nausea and vomiting in pregnancy. Okay. And if it is persisting beyond 16 weeks, then again, you have to reconsider other alternative diagnoses. Okay. And they said ketonuria occurs in normal pregnancy. So it's not, very important thing alone to determine the severity, admission or discharge. Okay. Mild elevation is likely. However, if mild ALT, AST's elevation become severe, and severe, if it is more than 100 or at 100, this is bad thing. This is not typical picture of nausea, vomiting in pregnancy. Our patient is having fever, progressively increase in the trend or hypoglycemia. Then you have to do this workup. Like you have to repeat blood, ALT, AST, and whole enzymatic workup, coagulation screen, albumins, like hepatic tests, all autoimmune screening, and amylase test, and you have to like do certain imaging as well, including gallstone, biliary tree imaging. Okay. So the liver test may increase physiologically later in pregnancy due to the placental production. Do not automatically attribute jaundice and like severe pain to hyperemesis gravidarum, because we can't see, this is not typical picture of hyperemesis. If severe pain, this can be due to the abduction. Rule out other causes. Whenever you will see that patient is having mild symptoms or mild score, like take her history, exclude the red flags, give her dietary advice, avoid the triggers, give her oral antibiotics because it is mild. and provide her red flags whenever she will face any, she should come immediately. Okay. Now, how you will investigate if she is having, peak score 7 to 12, right? If 7 to 12 peak score, you have to admit in ambulatory or daycare, where she can have IV fluids, potassium and normal saline with potassium, okay? And specifically, you have to replace potassium if potassium is less than 3.2. Remember this value. And you have to assess her peak score more frequently. And if by the end of the day she is okay, you can discharge. But still, if she need IV fluid, then you have to, daycare will close at evening, so you have to admit her in ward, okay? And discharge only if she is taking oral and her ketones are clear. But if she is like having, she's unwell, having abnormal electrolytes, she's unable to tolerate medication or any red flag, then you have to actually keep her as inpatient care, okay? So now we will do PEEP score 13. So at PEEP score 13, obviously you have to admit inpatient inside ward. You have to stabilize her, IV access, strict intake output record, correct her hypovolemia, give her potassium replacement, and biochemical correction. If she is having low glucose or she is diabetic, then we can have high glucose as well. And witty prophylaxis, pharmacological and mechanical measures, and then regular antibiotics combined with multiple classes. Multiple classes are better as compared to solo classes. We have covered it in theory as well. Okay. So this is the way we will actually treat hyperemesis. First, we give her first line, which is 𝗏𝗏𝗃. If not, then we will add second line, and gradually we will, add things. And if it is refractory, then we can add steroids as well. We will add steroids only after trying IV fluids, thiamine, electrolyte correction, like maximum conventional antiemetics, exclusion of alternative diagnosis, then we will add steroids. So in Vernix, we have to give thiamine before or with any dextrose containing fluid, otherwise it will aggravate. And patient is having diabetes, she can develop with this complication decay as well. Okay, so this is the discharge criteria. If she's taking oral fluids and her electrolytes are okay, and she's taking oral antiemetics. Okay, if she's anything is a red flag, you will admit, and if any recurrence, you will again review. So now with this concept, we will do this hyperemesis things. Just you have to revise the tables. I just covered it for you people. This is important and older guideline, like at 13 inpatient, 7-12 daycare, and at 6 and less than 6 community care. Okay, and remember, you must know when to investigate and which investigation you need. It depends on criteria, actually on PEEP score. Like if PEEP score is moderate, then you have to take full history, you have to take urine dipstick, you have to take her CBC, urea, electrolytes, you have to take LFTs and TFTs as well. Okay, and first you will send her MSU, and after this you will see for culture and take her BMI and these things. And you will do ultrasound as well, so that you can see this is twin or molar as well. And okay, yes. So I have covered it, I think. So there is nothing left behind now. Okay, so first treatment is caribin, which is actually combination of pyridoxine and doxylamine. And then we will add one of any promethazine, prochlorperazine, or cyclizine in caribin. Okay. And if she is dehydrated, then we have to give IV fluids with Pabrinex. Remember, if she is dehydrated, then you have to give IV fluids with thiamine. We say this is Pabrinex. And we will consider if patient is not covering with first line, then actually we will add combinations and we can, see if it is refractory to steroids, we will check her. This is very important. Basic is your 𝗂𝗵𝗃, and in 𝗂𝗵𝗃 you will add any 1, 2, 3, 4. If she is having dehydration, then you will actually admit her inpatient or daycare depending on her PUC score. Okay, and if her potassium is less than 3.2 specifically, you will resolve this. And if not tried previously, then you can add even after correction of dehydration, promethazine and these other things if not given already. However, if no dehydration and she can take oral, so we can give her and first line she is not recovering with first line and she is not dehydrated as well. So we can add prochlorperazine and promethazine and ondansetron after this. Okay, so we have seen hydration and dehydration both pathways. So quickly now I think you can complete molar questions. Okay, molar, but I want to say hyperemesis questions. So question number 1. 27, 11 weeks, severe nausea and vomiting, and she is unable to tolerate fluids for 48 hours. And she's having, ketones plus. So low molecular, no. IV fluid, yes. Antibiotics, no need. Oral, she can't tolerate. NGY, so you can easily eliminate. She need IV fluid resuscitation because she's unable to tolerate any oral. Now again, at 10 weeks, and she's having sign of dehydration with ketonuria. So she needs sodium chloride. Obviously, this is ideal. Oral, not possible in her case. Steroids in refractory only, not ideal. Dietary, she can't tolerate. Admission for observation alone, not ideal. So we can easily eliminate. This is intravenous sodium. Okay. Now this is important. Look at her ALT. This is not normal. If ALT are rising high, this is red flag. We have to exclude other causes as well, which can cause higher ALT. However, her bilirubin platelets are okay, but still she is having hyperemesis, ketonuria, and ALT 100. So at this, it's not a routine or typical hyperemesis. We have to exclude so many things. So obviously dehydrated ketones positive, IV fluids, antiemetics, and because of this abnormal pattern, we have to rule out other internal hepatic issues as well. So option A is better or option B is better. You can refer to hepatology, and actually option C is better. You can repeat in 3 months, IV fluids, and repeat LFTs after dehydration or start steroids. So what is the logical sequence? Logical sequence is that right now she is actually dehydrated. You have to give her fluids. And after rehydration, you have to reevaluate, retest her labs and check if any improvement. If improved, then it's mean that was exaggerated response of her liver because of dehydration. If not improved, then you will actually refer her and they will run hepatic screening test. So this is the stepwise approach. Okay, got it? Agree? Yes. So after rehydration, you will repeat LFTs, and if still 100, then you will refer her to hepatology. That this is not likely hyperemesis now. Okay. Then 12 weeks ketones, ALT, again same question. And 26-year-old woman to 8 weeks admitted ketones, and again, I wonder why it's repeating again and again, because here is no repetition after rehydration. So what we will do, we can opt B. I think it should be B. So hepatic screen we can do, but screening is not comes in our domain. It's not our domain. We don't know which test we should do. Only a hepatologist has better understanding. And if no B, then E can be the next, okay? And what he will do, he will look for, hepatitis A, B, C, and, imaging, so many things, because it's his specialty. 24-year patient, 12 weeks, ALT, and okay, IV fluids, and here only, it's not urgent. She is having, they have not mentioned dehydration, I am assuming, if it is the same question. If she is dehydrated, we will actually rehydrate her first. And we should give her antiemetics, because 𝗪𝗵𝗪𝗂𝗪 is a exaggerated form of nausea and vomiting. We used it when there is, significant weight loss and so many things. So I think option A is logical. Although it's not very perfect key, because they have not specifically mentioned dehydration, but they have mentioned hyperemesis gravidarum, so it's mean actually this definition is more aggressive by default. Actually now 8 weeks and 3+, and she's tolerating SIPs. Okay, so she is okay, fine. She is now taking oral. So we will continue her oral, the same. Ondansetron not needed. And okay, she will continue in community oral antiemetics. With this, we can add only Pabrinix and vitamins. What do you say? However, take its screenshot. Because the Pabrinix we gave when IV fluid is needed. Now they said IV fluid, actually dehydration has been done, and now she's tolerating SIPs. So I wonder why A even. But right now only A is looking eliminated key, but we will come later on this point. Okay. A woman with prolonged vomiting needs thiamine to prevent burnings, I know, and it must be given before glucose-containing fluids. Antiemetics are used alongside, but do not address the deficiency. She should not be discharged until thiamine has been given. Okay, I got it. So they said she has taken IV fluid. So any indication of IV fluid, so that with this we have to give Pabrinix. We give them together. So they have given her IV fluid, so next is Pabrinix. So it makes sense. 37, and look at her ALT. I think the same question is coming with multiple choices. Leave it. And now she is unable to tolerate fluid. And again, as ketones, so IV fluids, and obviously thiamine. Okay. And here ALT 100, and again repeating the same question. So first line is, they are asking the first line, as this is, mild PUC score, we will manage this patient in community and we will give oral first line, and this is carabine, and after carabine, this is cyclosine. Okay. So first line are these H2 blockers, H1 blockers, I guess, and with pyridoxine, and second line are metoclopramide with ondansetron, and then we will treat as refractory, and third line will be steroids. Okay. Now again, same thing, actually they said IV fluids, antiemetics, 𝗀 hepatology. 𝗀 hepatology, I think, in my opinion, right now I think B is more okay. Because hepatic screen definitely we will do, but in my opinion, why when we have a team of specialist doctor? Okay. And miscellaneous questions. 3 miscellaneous questions. And before these 3 miscellaneous questions, just do this guide. This is fetal anatomy 2018 Irish guideline. They said you have to do an anomaly scan between 18 and 22. If patient is obese, then better to do in 20 to 22 or in later half. If scan is complete, so offer repeat scan as soon as possible, and aim is to complete by 26 weeks. And if anything odd, involve fetal medicine specialist. If placenta is within 20 mm, repeat scan at 30 to 34. And if you are suspecting placenta adherent spectrum, then refer timely before 24 weeks in fetal medicine. If cord insertion, you have to check cord in all scans, and any issue in it, then you have to run like growth scans. And if 𝗪𝗶𝗹𝗪 factors, you have to add Doppler in it via TVS and refer at the same time the fetal medicine unit. This is important. If patient is having choroid plexus cyst, no further investigation. If having single uterine artery, then assess kidneys and do her third scan trimester. If renal pelvis dilatation more than 7 mm, repeat scan at 30 to 34. Absent nasal bone with low risk NIPS, not high risk, so no need to worry. However, if knuckle fold thickness is 6 mm, then you need detailed fetal echocardiography. If patient is having short femur and humerus with low risk NPS, you will just run third trimester growth scan. If hydrocephalus, you will refer. Echogenic bowel, you will refer. Okay, referral standards, you should refer them within 5 working days. With major anomalies, even within 3 working days. Okay, so now here are only 3 last questions. So a patient is having primary gravitas is having routine fetal anatomy scan at 21 weeks. Placenta is 15 mm, means within 20 mm from os. So you will repeat her ultrasound at 32, 34 for previous. During 20 weeks anomaly scan, isolated echogenic foci. For isolated echogenic foci, we do nothing. And she's having NIPS low risk as well, so no further investigation. But here she is having, like you are unable to see cardiac views, so you have to refer her. Okay. Okay, thank you. We made it together. Thank you so much. Now onward, now you can't face any issue in early pregnancy, trust me. Thank you for your patience and for this giant, long session. But I covered theory as well. Okay. Any query? No. Next class will be on, I guess, on antenatal module. Yes. Already planner I have shared with you people. And if any new person want to join us, then you can join us. Number on my PPT, you can see on footer side. So tomorrow we will do 2017 paper on Telegram. And after completing 2017, both papers, there will be module wise in the calls. Okay, probably it will be on internet. I'm looking at your queries now. Thank you very much. No queries, but lot of emojis. Okay, thank you. Thank you so much for this live. Okay, I know that class was lengthy because early pregnancy deserves this. It will be difficult for you to handle miscarriages scenarios, trust me. And next time we will keep class short because today we have done introduction as well. We have done, so many basic things, how to attempt paper and For revision, I am giving you a hint. Do not listen the lecture again. Just read my PPT slides. I will upload my whole lecture PPTs on your portal. And when you will read the slides, you will actually feel that you are listening me, and you can easily, quickly, within an hour, complete the whole early pregnancy, all slides. Okay. So anyone who is joining us in our course can join the portal as well. Before this, you have to subscribe the course. Galaxy. So in a week, there will be 2 to 3 classes. Minimum will be 2 classes, and it depends on your stamina. Then we can take 3 as well. Yes. For module wise, I trust me, module wise classes will be enough. Your module will revise. That's why I introduced this, so that like you don't have to cram recalls blindly. Okay, so I think I have answered all queries. Time to say goodbye. I will wait for your feedback on Telegram and on WhatsApp. Okay. Thank you very much.